Esophageal neuromuscular function and motility disorders. John E. Pandolfino, Peter J. Carlilis. 44. The esophagus is a muscular tube with a sphincter at each end joining the hypopharynx to the stomach with the simple function of transporting food, fluid, and gas between these endpoints. As such, the esophagus encompasses the anatomic and physiologic transition from the striated muscle oropharynx and the smooth muscle gut. Neurologically, the oropharynx is controlled by the cerebral cortex and medulla and capable of precise tactile sensation. The distal esophagus is composed entirely of smooth muscle, controlled by the vagus nerve and enteric nervous system, and comparatively insensitive. Although there is a gradual transition between these endpoints, motor function in the oropharynx and esophageal body are quite distinct. With that in mind, the ensuing discussion includes selected aspects of pharyngeal, gastric, and diaphragmatic function that are inextricably entwined with esophageal function. Motor and sensory function. Oropharynx and upper esophageal sphincter within the oral cavity, the lips, teeth, hard palate, soft palate, mandible, floor of the mouth, and tongue serve to form and contain food into a bolus suitable for transfer to the pharynx. The pharynx is divided into three segments: nasopharynx, oropharynx, and hypopharynx, Fig. 44.1. The nasopharynx extends from the base of the skull to the distal edge of the soft palate. Muscles in the nasopharynx elevate the soft palate during swallowing, seal the nasopharynx, and prevent nasopharyngeal regurgitation. The oropharynx extends from the soft palate to the base of the tongue. The inferior margin of the oropharynx is demarcated by the valleculae anteriorly and the mobile tip of the epiglottis posteriorly. The hypopharynx extends from the valleculae to the inferior margin of the cricoid cartilage and includes the upper esophageal sphincter, UES. Musculature of the soft palate, tongue, and pharynx all participate during swallowing to collapse and shorten the pharyngeal lumen and then expel its contents into the esophagus. Additionally, extrinsic muscles elevate and pull the pharynx forward, thereby sealing the airway and opening the UES. The intrinsic muscles of the pharynx, the superior, middle, and inferior pharyngeal constrictors, see Fig. 44.1, overlap and insert into a collagenous sheet, the buccopharyngeal aponeurosis. The inferior constrictor is composed of the thyropharyngeus, superior part, and the cricopharyngeus, inferior part. The thyropharyngeus arises from the thyroid cartilage, passes posteromedially, and inserts in the median raphe. The cricopharyngeus has superior and inferior components, each of which arise bilaterally from the sides of the cricoid lamina. The superior fibers course posteromedially to the median raphe whereas the inferior fibers loop around the esophageal inlet without a median raphe. Killian triangle, a triangular area of thin muscle, is formed posteriorly between these components and is the most common site of origin for pharyngeal pulsion diverticula. The pharynx also contains 5 single or paired cartilages, see Fig. 44.1. The spaces formed between the lateral insertion of the inferior constrictor and the lateral walls of the thyroid cartilage are the pyriform sinuses that end inferiorly at the cricopharyngeus muscle, separating the pharynx from the esophagus. The larynx and trachea are suspended in the neck between the hyoid bone superiorly and the sternum inferiorly. A number of muscles, categorized as the laryngeal strap muscles, contribute to this suspension and, together with the intrinsic elasticity of the trachea, permit the larynx to be raised and lowered. The hyoid bone also serves as the base for the tongue that rests upon it. Laryngeal movement is crucial to the swallow response as the laryngeal inlet is both closed and physically removed from the bolus path in the course of a swallow. Failure to achieve this synchronized laryngeal movement can result in aspiration. The pharyngeal muscles are densely innervated with motor fibers coming from nuclei of the trigeminal, facial, glossopharyngeal, and hypoglossal nuclei, as well as the nucleus ambiguus of the vagus and spinal segments C1 to C3. All motor neurons within nucleus ambiguus participate in swallowing, with those innervating the striated muscle esophagus situated rostrally and those innervating the pharynx and larynx more caudally. 1. The muscular components of the UES are the cricopharyngeus, adjacent esophagus, and adjacent inferior constrictor, with the cricopharyngeus contributing the 1 cm zone of maximal pressure. 2. The closed sphincter has a slit-like configuration, with the cricoid lamina anterior and the cricopharyngeus lateral and posterior. Neural input via vagal trunks originating in the nucleus ambiguous maintains UES pressure, and vagal transection abolishes this contractile activity. Manometric evaluation of UES function is difficult because it is a short, complex anatomic zone that moves briskly during swallowing. Furthermore, UES pressure is heavily influenced by recording methodology, owing both to its marked asymmetry and to its reflexive contraction to pharyngeal and esophageal stimulation. Thus, it is not possible to define a meaningful normal range of UES pressure. 3. UES relaxation during swallowing also poses substantial recording challenges, making for great variability in technique and interpretation. However, HRM using solid-state technology permits accurate tracking of UES relaxation and intrabolus pressure changes during swallowing. Fig. 44.2. The UES maintains closure of the proximal end of the esophagus unless opening is required, necessitated for swallowing or belching. It also constitutes an additional barrier to refluxed material entering the pharynx from the esophagus and prevents air from entering the esophagus by contracting in synchrony with inspiration. Inspiratory augmentation is most evident during periods of low UES pressure and can be exaggerated in individuals experiencing globus sensation. 4. Balloon distension of the esophagus stimulates UES contraction. 5. With the effect being more pronounced with proximal balloon positions. However, when the distension pattern of gas reflux is simulated using a cylindrical bag or rapid air injection into the esophagus, UES relaxation rather than contraction occurs. 2. Belch-induced UES relaxation is also associated with glottic closure. Stress augments UES pressure, whereas anesthesia, or SLEEP6, virtually eliminates it. Neither experimental acid perfusion of the esophagus nor spontaneous gastroesophageal acid reflux alters continuously recorded UES pressure in either normal volunteers or in individuals with peptic esophagitis. The pharyngeal swallow disorders of the oral phase of swallowing occur with many conditions characterized by global neurologic dysfunction, such as traumatic brain injury, brain tumors, or chorea. See Chapter 37. Detailed discussion of these conditions can be found in texts on swallow evaluation and therapy. 7. The pharyngeal swallow is the largely subconscious coordinated contraction that transfers oral contents into the esophagus. Afferent sensory fibers capable of triggering the pharyngeal swallow travel centrally via the internal branch of the superior laryngeal nerve, from the larynx, and the glossopharyngeal nerve, from the pharynx. These sensory fibers converge before terminating in the medullary swallow center. Although understood physiologically as the patterned activation of motor neurons and their corresponding motor units, swallowing is clinically evaluated in mechanical terms and best evaluated by video fluoroscopic or cineradiographic analysis. The pharyngeal swallow rapidly reconfigures pharyngeal structures from a respiratory to an alimentary pathway and then reverses this reconfiguration within 1 second. The pharyngeal swallow response can be dissected into several closely coordinated actions. 1. Nasopharyngeal closure by elevation and retraction of the soft palate. 2. UES opening. 3. Laryngeal closure. 4. Tongue loading, ramping. 5. Tongue pulsion, and 6. Pharyngeal clearance. Precise coordination of these actions is an obvious imperative, and to some degree the relative timing of these events is affected either by volition or by the volume of the swallowed bolus. See Fig. 44.2. The most fundamental anatomic reconfiguration required to transform the oropharynx from a respiratory to a swallow pathway is to open the inlet to the esophagus and seal the inlet to the larynx. These events occur in close synchrony, facilitated by laryngeal elevation and anterior traction via the hyoid axis. It is critical to recognize the distinction between UES relaxation and UES opening. UES relaxation is due to cessation of excitatory neural input while the larynx is elevating. Once the larynx is elevated, UES opening results from traction on the anterior sphincter wall caused by contraction of the supra- and infrahyoid musculature that also results in a characteristic pattern of hyoid displacement. Bolus transport out of the oropharynx is facilitated by the tongue and pharyngeal constrictors. Tongue motion adapts to varied swallow conditions and propels most of the bolus into the esophagus prior to the onset of the pharyngeal contraction. On the other hand, the pharyngeal contraction is more stereotyped, functioning to strip the last residue from the pharyngeal walls. UES closure coincides with passage of the pharyngeal contraction. Mylohyoid thyrohyoid membrane vocal cord transverse arytenoid cricothyroid membrane cricoid cartilage AB oral pharynx valleculae hyoid bone epiglottis laryngeal pharynx, hypopharynx, esophagus buccinator lateral pterygoid plate digastric, ant belly, mylohyoid stylohyoid hyoid bone thyroid cartilage cricothyroid membrane cricoid cartilage digastric, post belly, superior constrictor styloid process styloglossus stylohyoid ligament glossopharyngeus. Stylopharyngeus middle constrictor hyoglossus thyrohyoid membrane inferior constrictor cricopharyngeus esophagus soft palate hard palate oral cavity tongue Fig 44.1 Anatomy of the pharynx. A. Sagittal view of the pharynx showing the musculoskeletal structures involved in swallowing. Note that the esophagus is collapsed and empty at rest. In the course of a swallow, the laryngeal inlet will be sealed and the mouth of the esophagus will be opened by highly coordinated muscular activity. B. Cutaway view of the musculature of the pharynx. Note that the hyoid bone is positioned as a fulcrum and is instrumental in directing anterior, superior traction forces critical to closing the larynx and opening the esophageal inlet during a swallow. And anterior, posterior. Reprinted from Carr-Eilis P.J., Frost F. Disorders of Swallowing and Bowel Motility. In, Green D., Editor. Medical Problems of the Chronically Disabled. Rockville, M.D., Aspen Publishers, 1990. p. 1137. 640 Part V. Esophagus. However, the contractile activity of the sphincter has an added dimension as well, exhibiting augmented contractility during laryngeal descent, resulting in a grabbing effect such that the sphincter and laryngeal descent complement each other to clear residue from the hypopharynx. 8 This clearing function probably acts to minimize the risk of post-swallow aspiration by preventing residual material from adhering to the laryngeal inlet when respiration resumes. Esophagus. The esophagus is a 20 to 22 cm tube composed of skeletal and smooth muscle. The proportion of each muscle type is species dependent, but in humans, the proximal 5% is striated, the middle 35% to 40% is mixed with an increasing proportion of smooth muscle distally, and the distal 50% to 60% is entirely smooth muscle. The outer longitudinal muscle arises from the cricoid cartilage with slips from the cricopharyngeus passing dorsolaterally to fuse posteriorly about 3 cm distal to the cricoid cartilage. This results in a posterior triangular area devoid of longitudinal muscle, lamar triangle. Distal to lamar triangle, the longitudinal muscles form a continuous sheath of uniform thickness around the esophagus. The adjacent, inner muscle layer is formed of circular or, more precisely, helical muscle also forming a sheath of uniform thickness along the length of the esophagus. There is a decreasing degree of helicity moving distally ranging from 60 degrees in the proximal esophagus to nearly 0 degrees at the lower esophageal sphincter, lay. 0.9 Unlike the distal GI tract, there is no serosal layer to the esophagus. The extrinsic innervation of the esophagus is via the vagus nerve with motor neurons and nucleus ambiguous, striated muscle portion, and the dorsal motor nucleus of the vagus, smooth muscle portion. Efferent vagal fibers reach the cervical esophagus by the pharyngoesophageal nerve, and synapse directly on striated 150-150 mmHg30. Velopharyngeal junction closure. Laryngeal vestibule closure. UES opening 1 2 3 4 5 6 7 0.1 SEC glossopalatal junction opening. Fig 44.2 Fluoroscopy combined with high-resolution manometry, HRM. The fluoroscopic images, top, are depicted at specific times demarcated on the HRM color panel by pink arrows. The timeline illustrates the coordination and timing of events within the pharyngeal swallow on fluoroscopy. Each horizontal bar depicts the period during which one of the oropharyngeal valves is in its swallow configuration, as opposed to its configuration during respiration, and is correlated with the images on fluoroscopy. 1. Baseline anatomy with bolus in the mouth. 2. Glossopalatal opening occurring in synchrony with UES relaxation, which is typically to less than 10 mm Hg. 3. Velopharyngeal junction closure, sealing off the nasopharynx to prevent regurgitation. Note the elevation depicted by the white arrow. 4. Laryngeal vestibule closure and UES opening occurring as the epiglottis inverts, closing the laryngeal vestibule as the bolus, led by air, is rapidly pushed through the UES. 5. Continued bolus transit with the onset of the pharyngeal stripping wave. 6. Bolus transfer to the esophagus is completed as the pharyngeal stripping wave traverses the UES while the laryngeal vestibule remains closed. 7. Return of the pharynx to a respiratory configuration, with the laryngeal vestibule opened and the epiglottis back in its upright configuration. The black dots on the topography, HRM, plot represent the location of the proximal aspect of the UES at each time point. With permission from the Esophageal Center at Northwestern. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 641-44 Muscle Neuromuscular Junctions. The vagus also provides sensory innervation, in the cervical esophagus. This is via the superior laryngeal nerve with cell bodies in the nodose ganglion, whereas in the remainder of the esophagus, sensory fibers travel via the recurrent laryngeal nerve or, in the most distal esophagus, via the esophageal branches of the vagus. Vagal afferents are strongly stimulated by esophageal distension. The esophagus also contains an autonomic nerve network, the myenteric plexus, located between the longitudinal and circular muscle layers. Myenteric plexus neurons are sparse in the proximal esophagus, and their function is unclear because the striated muscle is directly controlled by nucleus ambiguous motor neurons. On the other hand, in the smooth muscle esophagus preganglionic neurons in the dorsal motor nucleus of the vagus synapse on relay neurons in the myenteric plexus ganglia. A second nerve network, the submucosal or Meissner plexus, is situated between the muscularis mucosa and the circular muscle layer, but this is sparse in the human esophagus. Esophageal peristalsis. The esophagus is normally atonic and its intraluminal pressure closely reflects pleural pressure, becoming negative during inspiration. However, swallowing or focal distension initiates peristalsis. Primary peristalsis is initiated by a swallow and traverses the entire length of the esophagus. Secondary peristalsis can be elicited in response to focal esophageal distension with air, fluid, or a balloon, beginning at the locus of distension. The mechanical correlate of peristalsis is of a stripping wave that milks the esophagus clean from its proximal to distal end. The propagation of the stripping wave corresponds closely with that of the manometrically recorded contraction, such that the point of luminal closure seen fluoroscopically at each esophageal locus corresponds with the upstroke of the pressure wave on line tracings or the contractile wave front on esophageal pressure topography, EPT, Fig 44.3. The likelihood of achieving complete esophageal emptying from the distal esophagus is inversely related to peristaltic amplitude. 150-150 mmHg 30 UES EGJ 10S 05 10 15 20 25 30 35 length along the esophagus, cm, time, SEC, EGJ relaxation P, transition zone, D segment 1 segment 3 segment 2 MCDP DL time, SEC, A, segmental architecture, B, landmarks of propagation CFV Fig 44.3 topographic depiction of esophageal peristalsis using HRM showing the segmental architecture of peristalsis and landmarks of contractile propagation. A, the 30 mmHg isobaric contour plot, black lines, demonstrates that progression through the esophagus is not seamless. The proximal striated segment 1 and the distal smooth muscle esophageal contractile segments 2 and 3 are separated by a transition zone, P. The distal esophagus is also divided into two distinct contractile segments, 2 and 3, separated by a pressure trough, M. The region of the EGJ is also distinguished by a distinct contractile segment that is separated from the adjacent esophagus by another pressure trough, D. B. Same depiction with the topographic landmarks of peristalsis represented. The pink circle located within segment 3 localizes the CDP, the point along the contractile wavefront at which velocity slows, demarcating the transition from peristalsis to sphincter reconstitution. The DL, which is a manifestation of deglutitive inhibition, is measured from UES relaxation to the CDP. Contractile front velocity is measured by taking the best fit tangent from the CDP to the transition zone, P. Of interest is the concept of concurrent esophageal contraction illustrated by the vertical dashed arrows. The length of the esophagus concurrently contracting, between the onset of the contractile front and the offset of contraction proximally, is, on average, 10 cm and maximizes in close approximation to the CDP. Following the CDP, the length of concurrent contraction lessens as the rear catches up with the slowed contraction front. With permission from the esophageal center at northwestern 642 part V esophagus such that emptying becomes progressively impaired with peristaltic amplitudes of 30 mm Hg or less. 10 However, emptying is also modified by the pressure gradient across the esophagogastric junction, EGJ, and this interaction can have significant influence on both bolus transit and peristaltic contractility. Another essential feature of peristalsis is deglutitive inhibition. A second swallow initiated while an earlier peristaltic contraction is still progressing in the proximal esophagus completely inhibits the contraction induced by the first swallow. Deglutitive inhibition in the distal esophagus is attributable to hyperpolarization of the circular smooth muscle and is mediated via inhibitory ganglionic neurons in the myenteric plexus. Deglutitive inhibition can be demonstrated experimentally in the esophagus by distending an intraluminal balloon, which stimulates esophageal contraction. 11 Once the high-pressure zone is established, deglutitive inhibition is evident after swallowing while recording intraluminal pressure between the balloon and the esophageal wall. The physiologic control mechanisms governing the striated and smooth muscle esophagus differ. The striated muscle receives exclusively excitatory vagal innervation, and its peristaltic contraction results from sequential activation of the musculature. These vagal fibers release acetylcholine, ACH, and stimulate nicotinic cholinergic receptors on the striated muscle cells. Striated muscle peristalsis is programmed by the medullary swallowing center in much the same way as is the pharyngeal swallow. The vagus nerves also exhibit control of primary peristalsis in the smooth muscle esophagus, but the mechanism of vagal control is more complex than that of the striated muscle because vagal fibers synapse on myenteric plexus neurons rather than directly on muscle cells. However, the myenteric plexus can also orchestrate peristalsis independently of vagal activation. Secondary peristalsis can be elicited anywhere along the smooth muscle esophagus despite extrinsic denervation. In contrast, transection across the striated muscle esophagus does not inhibit peristaltic progression across the transection site or distally. Regardless of central or ganglionic control, esophageal smooth muscle contraction is ultimately elicited by ganglionic cholinergic neurons. Less clear are the control mechanisms for the direction and velocity of peristalsis. Nerve conduction studies indicate that neural stimuli initiated by swallowing reach the ganglionic neurons along the length of the esophagus essentially simultaneously. However, the latency between the arrival of the vagal stimulus and muscle contraction progressively increases, moving Aber-Ally. In humans, the latent period is 2 seconds in the proximal smooth muscle esophagus and 5 to 7 seconds just proximal to the less. The current hypothesis is that peristaltic direction and velocity result from a neural gradient along the esophagus, wherein excitatory ganglionic neurons dominate proximally and inhibitory ganglionic neurons dominate distally, Fig 44.4. This organization is consistent with the demonstration of two subsegments within the smooth muscle segment with pressure topography plotting, the first of which is strongly reactive to cholinergic drugs. 12 The primary inhibitory neurotransmitter is nitric oxide, NO, produced from L-arginine by the enzyme no synthase in myenteric neurons. 13 There is also evidence for a role of vasoactive intestinal polypeptide, VIP, containing neurons mediating inhibition. 14 High-resolution EPT allows for the imaging of esophageal contractility as a continuum not only in time, but also along the length of the esophagus. Klaus and colleagues pioneered this technology, noting that peristalsis was not a seamless wave of pressurization, but rather a coordinated sequence of 4 contiguous contractile segments, see Fig. 44.3. A transition zone exists between the first and second segments, characterized by the nadir peristaltic amplitude, slightly delayed progression, and occasional failed transmission. The topographic analysis also reveals a segmental characteristic of peristaltic progression within the smooth muscle esophagus, with 2 contractile segments separated by a pressure trough, followed by the less, which contracts with vigor and persistence quite dissimilar to the adjacent smooth muscle esophagus. 15 More recently, a distinct landmark along the wave front was recognized localized in the third segment, at which point contractile propagation slows dramatically, see Fig. 44.3.16. This landmark, defined as the contractile deceleration point, CDP, has pathophysiologic significance because it is localized at the proximal aspect of the less, and it is hypothesized that this represents the locus of termination of peristalsis. 17 Contraction beyond this point is more consistent with reconstitution of the less that was relaxed, elongated, and effaced during peristalsis to form the phrenic ampulla. Longitudinal muscle. The longitudinal muscle of the esophagus also contracts during peristalsis, with the net effect of transiently shortening the structure by 2 to 2.5 cm. Similar to the pattern of circular muscle contraction, longitudinal muscle contraction is propagated distally as an active segment at a rate of 2 to 4 cm/s. 18 Central mechanisms control longitudinal muscle contraction during peristalsis with progressively increasing latency moving distally, similar to that seen with the circular smooth muscle. However, unlike the circular muscle, nerve stimulation studies suggest the longitudinal muscle to be free of inhibitory neural control. Esophagogastric junction, EJG. The anatomy of the EGJ is complex, see also Chapter 43. The distal end of the esophagus is anchored to the diaphragm by the phrenoesophageal ligament that inserts circumferentially into the esophageal musculature close to the squamocolumnar junction, SCJ. The esophagus then traverses the diaphragmatic hiatus and joins the stomach almost tangentially. Thus, there are 3 contributors to the EGJ high pressure zone: the less, the crural diaphragm, and the musculature of the gastric cardia that constitutes the distal aspect of the EGJ. The less is a 3 to 4 cm segment of tonically contracted smooth muscle at the distal extreme of the esophagus. Surrounding the less at the level of the SCJ is the crural diaphragm, most commonly bundles of the right diaphragmatic crus forming a teardrop-shaped canal about 2 cm long on its major axis, Fig. 44.5.19. The component of the EGJ high-pressure zone distal to the SCJ is largely attributable to the opposing sling and clasp fibers of the middle layer of gastric cardia musculature. 20 In this region, the lateral wall of the esophagus meets the medial aspect of the dome of the stomach at an acute angle, defined as the angle of His. Viewed intraluminally, this region extends within the gastric lumen, appearing as a fold that has been conceptually referred to as a flap valve because increased intragastric pressure forces it closed, sealing off the entry to the esophagus. Physiologically, the EGJ high-pressure zone is attributable to a composite of both the less and the surrounding crural diaphragm extending 1 to 1.5 cm proximal to the SCJ and about 2 cm distal to it. 21 Resting lay tone ranges from 10 to 30 mm Hg relative to intragastric pressure, with considerable temporal fluctuation. With HRM, this is quantified as the EGJ contractile integral, and the normal value ranges from 28 to 125 mm Hg/cm. 22 The mechanism of lay tonic contraction is likely both myogenic and neurogenic, consistent with the observation that pressure within the sphincter persists after elimination of neural activity with tetrodotoxin. Myogenic lay tone varies directly with membrane potential that leads to an influx of Ca2+. Apart from myogenic factors, lay pressure is also modulated by intra-abdominal pressure, gastric distension, peptides, hormones, foods, and many medications. Large increases in lay pressure occur with the migrating motor complex. During phase 3 of the migrating motor complex, the less pressure may exceed 80 mm Hg. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 643-44 Lesser fluctuations occur throughout the day, with pressure decreasing in the postprandial state and increasing during sleep. 23 Superimposed on the myogenic less contraction, input from vagal, adrenergic, hormonal, and mechanical influences will alter lay pressure. Vagal influence is similar to that of the esophageal body, with vagal stimulation activating both excitatory and inhibitory myenteric neurons. Thus, the less pressure at any instant reflects the balance between excitatory, cholinergic, and inhibitory, nitroergic, neural input, and altering the pattern of vagal discharge results in lay relaxation. The crural diaphragm is also a major contributor to EGJ pressure. Even after esophagogastrectomy, with consequent removal of the smooth muscle lay, a persistent EGJ pressure of about 6 mm Hg can be demonstrated during expiration. During inspiration, there is substantial augmentation of EGJ pressure attributable to crural diaphragm contraction. Crural diaphragm contraction is also augmented during abdominal compression, straining, or coughing. 24 On the other hand, during esophageal distension, vomiting, and belching, electrical activity in the crural diaphragm is selectively inhibited despite continued respiration, demonstrating a control mechanism independent of the costal diaphragm. This reflex inhibition of crural activity is eliminated with vagotomy. Lay relaxation. Less relaxation can be triggered by distension from either side of the EGJ or swallowing. Relaxation induced by esophageal distension is an intramural process, unaffected by vagotomy. Relaxation is, however, antagonized by tetrodotoxin, proving that it is mediated by postganglionic nerves. Deglutative lay relaxation is mediated by the vagus nerve, which synapses with inhibitory neurons in the myenteric plexus. No, produced by no synthase from the precursor amino acid L-arginine, is the main neurotransmitter in the postganglionic neurons responsible for lay relaxation. No is released with neural stimulation in the esophagus, lay, and stomach, and no synthase inhibitors block neurally mediated lay relaxation. 13,25 However, no may not work alone. VIP-containing neurons have been demonstrated in the submucosal plexus, and VIP relaxes the less by direct muscle action. It is thought that VIP acts on no synthase-containing neural terminals as a prejunctional neurotransmitter, facilitating the release of NO and on gastric muscle cells to stimulate production of NO by the muscle. 26 Another contributor to intraluminal pressure during bolus transit through the less is the bolus itself. The less relaxes lay UES striated muscle, smooth muscle 3 cm 8 cm 3 cm 8 cm 200 mm Hg 200 mm Hg 0 mm Hg 0 mm Hg ABCD Fig 44.4 Alterations in the balance and gradient of excitatory, cholinergic, and inhibitory, nitroergic, neurons in the distal esophagus as a pathophysiologic mechanism of esophageal motor disorders. The upper panel depicts the ganglionic constituents in the esophagus, and the lower panel illustrates manometric tracings at 3 and 8 cm above the less. The blue circles represent excitatory neurons, and the red circles represent inhibitory neurons. In normal subjects, cholinergic neurons are most dense proximally, becoming increasingly sparse distally. Conversely, inhibitory neurons are more prominent distally and relatively sparse proximally. This inverse neural gradient causes increasing latency of the contraction as it progresses distally. With simultaneous vagal stimulation of ganglia along the length of the esophagus, contraction first occurs proximally and propagates distally only as the effects of increasingly dense inhibition wear off. Thus, pharmacologic manipulation can alter both contractile vigor and timing of propagation. Conceptually, esophageal motor pathophysiology can be explained by alterations in these neural gradients. Patients with hypercontractility and normal, or fast, propagation may have a relative increase in excitatory neurons. C. Patients with loss of inhibitory neurons will lose deglutative inhibition, and contractions will occur simultaneously and prematurely. D. Patients with loss of both excitatory and inhibitory neurons may present with absent or weak peristalsis that does not propagate. Modified from Goyal R., Shaker R., GI Motility Online. 644 Part V. Esophagus during the initial phase of the swallow, but it does not actually open until the bolus enters the sphincter, thereby implicating intrabolus pressure. Hence, EGJ opening is dependent on the balance of forces acting to open it, intrabolus pressure generated by peristalsis, and the forces resisting opening, lay tone and the mechanical properties of the esophageal wall and crural canal. Although each of these factors may dominate in a particular physiologic scenario, it is difficult to tease them apart with conventional manometric recordings. HRM with EPT has improved on this, and the current assessment of EGJ relaxation during swallowing uses an electronic sleeve or e-sleeve to ascertain the lowest average post-deglutative pressure for a 4-second time period, skipping inspiratory crural contractions if necessary, Fig 44.6. This measurement provides an integrated assessment of the pressure dynamics through the EGJ that is sensitive to both pathologic conditions resisting opening, such as impaired lay relaxation with achalasia, and mechanical obstruction at the EGJ related to a structural cause, stricture, tumor, lay hypertrophy. Transient lay relaxations during rest, the EGJ must prevent gastroesophageal reflux, but also must transiently relax to selectively permit gas venting of the stomach. These functions are accomplished by prolonged lay relaxations that occur without swallowing or peristalsis. These transient less relaxations, plessures, are an important mechanism in GERD pathogenesis and are the most frequent mechanism for reflux during periods of normal lay pressure, see Chapter 46. Plessures are distinguishable from swallow-induced relaxation in several ways. 1. They are prolonged, greater than 10 seconds, and independent of pharyngeal swallowing. 2. They are associated with contraction of the distal esophageal longitudinal muscle, causing esophageal shortening. 3. There is no synchronized esophageal peristalsis, and 4. They are associated with crural diaphragm inhibition, which is not the case with swallow-induced relaxation. Fig 44.7. Point 27,28 plessures occur most frequently in the postprandial state during gastric distension. In the setting of the completely relaxed EGJ during plessures, even the minimal gastroesophageal pressure gradients observed with gastric distension, 3 to 4 mm Hg, are sufficient to facilitate gas venting of the stomach. Thus, plessures are the physiologic mechanism of belching. Proximal gastric distension is the major stimulus for TLESR. Distension stimulates mechanoreceptors, intraganglionic lamellar endings, in the proximal stomach, activating vagal afferent fibers projecting to the nucleus of the solitary tract. The efferent limb of both swallow and non-swallow lay relaxations lies in the preganglionic vagal inhibitory pathway to the LES. Both types of relaxation can be blocked by bilateral cervical vagotomy, cervical vagal cooling, or no synthase inhibitors. Plessures triggered by gastric distension likely use NO and CCK as neurotransmitters, evident by increased TLESR frequency after 4-CCK infusion and blockade by either no synthase inhibitors or CCKA antagonists. Finally, GABAB agonists, such as baclofen, inhibit plessures, acting on both peripheral receptors and receptors located in the dorsal motor nucleus of the vagus. 29,30 Esophageal sensation. The human esophagus can sense mechanical, electrical, chemical, and thermal stimuli, perceived as chest pressure, warmth, or pain, with substantial overlap in perception among stimuli. 31 Esophageal sensation is carried via both the vagal and spinal afferent nerves. The associated vagal neurons are located in the nodose and jugular ganglia, whereas the corresponding spinal neurons are located in thoracic and cervical dorsal root ganglia. Vagal afferents predominantly mediate homeostatic and secretory functions, whereas spinal afferents project centrally in a pattern characterized by overlap among spinal segments and convergence with somatic afferents. Consequently, esophageal pain tends to be poorly localized, accompanied by referred somatic pain and subject to visceral hyperalgesia. 32 Esophageal sensations are usually perceived substernally. In the instance of pain, radiation to the midline of the back, shoulders, and jaw is very analogous to cardiac pain. These similarities are likely due to convergence of sensory afferent fibers from the heart and esophagus in the same spinal pathways, even to the same dorsal horn neurons in some cases. Esophageal afferents are predominantly activated by wall stretch, temperature, and acidity. When accompanied by mucosal injury, inflammatory mediators, prostaglandins, bradykinins, etc., augment the response. The proximal esophagus is more sensitive than the distal esophagus, consistent with the observation that proximal stimuli such as reflux are more likely to be perceived. 33 Excessive proximal sensitivity has been associated with esophageal hypersensitivity and functional heartburn. 34 With sensory endings concentrated deeply within the muscularis propria beneath a relatively impermeable mucosa, it seems unlikely that intraluminal acid can directly stimulate them. However, these afferents easily respond to mucosally applied bile or capsaicin, a derivative of chili pepper, suggesting that these chemicals induce the release of an endogenous substance that in turn excites the afferents. These responses are thought to be mediated by transient receptor potential vanilloid 1, TRPV1, receptors and/or acid-sensing ion channels. 35-36 Consistent with this, current evidence suggests that chronic esophagitis increases mRNA expression of purinergic receptors accompanied by upregulation of TRPV1 and neurotrophic factors mediating sensitization of the inflamed human esophagus. 37 Owing to its significance in the pathogenesis of GERD, there has been substantial interest in modulating the TLESR reflex, see Chapter 44. The current concept is that vagal afferent endings right cruce of diaphragm esophagus left cruce of diaphragm L1 aorta Fig 44.5 Anatomy of the diaphragmatic hiatus as viewed from below. The most common anatomy, in which the muscular elements of the crural diaphragm derive from the right diaphragmatic cruce, is shown. The right cruce arises from the anterior longitudinal ligament overlying the lumbar vertebrae. Once muscular elements emerge from the tendon, two flat muscular bands form that cross each other in scissor-like fashion, forming the walls of the hiatus and then merging with each other anterior to the esophagus. L1, first lumbar vertebrae. Modified from Jaffe BM Surgery of the Esophagus. In, Orlando R.C., Editor. Atlas of Esophageal Diseases. 2nd ed. Philadelphia, Current Medicine, Inc., 2002. p. 221-42. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 645-44 Terminating in intraganglionic lamellar endings located in the proximal stomach are primarily responsible for initiating the reflex, which is then mediated through the medulla and back to the esophagus and diaphragm via vagal efferents and the phrenic nerves. Pharmacologic and physiologic studies have demonstrated that the mechanotransduction properties of tension-sensitive vagal afferent fibers can be attenuated by the GABAB receptor agonist baclofen, thereby reducing the frequency of TLESR. Glutamate receptors are also present in vagal and spinal sensory afferent fibers, and metabotropic glutamate receptor antagonists, especially MGLUR5 antagonists, have also been shown to inhibit TLESR. 38 Recent investigations have also explored functional brain imaging, mainly functional magnetic resonance imaging, as a non-invasive assessment of brain function in visceral sensation and pain. 39 Although the results thus far are quite variable among research groups, the brain regions most consistently activated by esophageal stimuli are the anterior and posterior insula, cingulate cortex, primary sensory cortex, prefrontal cortex, and thalamus. Preliminary studies also suggest differences in functional magnetic resonance imaging activation patterns among subgroups of GERD patients and normal controls. 40 Esophageal motility disorders. A working, albeit restrictive, definition of an esophageal motility disorder is an esophageal disease attributable to neuromuscular dysfunction that causes symptoms referable to the esophagus, most commonly dysphagia, chest pain, or heartburn. Using this definition, there are only 3 firmly established primary esophageal motility disorders: achalasia, distal esophageal spasm, DE, and GERD. GERD is clearly the most prevalent among the group and, fittingly, it is addressed in detail elsewhere in this text, see Chapter 46. Esophageal motility disorders can also be secondary phenomena, in which case esophageal dysfunction is part of a more global disease, such as in pseudoachalasia, Chagas disease, and PSS, scleroderma. Dysphagia due to pharyngeal or UES dysfunction can also be included in a discussion of esophageal motor 030 mmHg mmHg 015 E-sleeve gastric length along the esophagus, cm. 05 10 15 20 25 0 180 60 40 20 30 35 1.6 mm Hg 1.6 mm Hg 2 SEC 2 SEC Fig 44.6 EGJ relaxation and bolus transit during swallowing. The IRP provides a pressure topography metric of the pressure dynamics across the EGJ during swallowing. The IRP is a complex metric because it involves accurately localizing the margins of the EGJ, demarcating the time window following deglutitive upper sphincter relaxation within which to anticipate EGJ relaxation, and then applying an E-sleeve measurement within that 10 SEC time box, delineated by the black brackets. The E-sleeve is referenced to gastric pressure and provides a measure of the greatest pressure across the axial domain of the EGJ at each time point and is plotted as a line tracing. The IRP is the mean value of the 4 SEC during which the E-sleeve value is the lowest. The time intervals contributing to the IRP are indicated by the white boxes on the plot and by the shaded red area on the red line E-sleeve tracing. In this example, the IRP is 1.6 mm Hg, which is normal. The EGJ is closed, and no flow occurs at the beginning of the swallow because the intrabolus pressure is insufficient to overcome EGJ pressure. Left fluoroscopic image. Bolus transit occurs when the intrabolus pressure ahead of the contractile wavefront overcomes the resisting forces at the EGJ, right fluoroscopic image. 646 Part V esophagus disorders, but this is usually as a manifestation of a more global neuromuscular disease process. The major focus of this chapter will be on the primary motility disorders, particularly achalasia. However, mention will be made of the secondary motility disorders and proximal pharyngoesophageal dysfunction when important unique features exist. Epidemiology estimates of the prevalence of dysphagia among individuals older than 50 years range from 16% to 22%, with most of this related to oropharyngeal dysfunction. Most oropharyngeal dysphagia is related to neuromuscular disease. The prevalence of the most common anatomic etiology, Zinker diverticulum, is estimated to range from a meager 0.01% to 0.11% of the population in the USA, with peak incidence in men between the 7th and 9th decades. 41 The consequences of oropharyngeal dysphagia are severe: dehydration, malnutrition, aspiration, choking, pneumonia, and death. Within healthcare institutions, it is estimated that up to 13% of hospitalized patients and 60% of nursing home residents have feeding problems and, again, most are attributed to oropharyngeal dysfunction as opposed to esophageal dysfunction. Mortality of nursing residents with dysphagia and aspiration can be as high as 45% over 1 year. As the U.S. population continues to age, oropharyngeal dysphagia will become an increasing problem associated with complex medical and ethical issues. Achalasia is the most easily recognized and best defined motor disorder of the esophagus. Modern estimates of the incidence of achalasia are about 2.9 per 100,000 population in the USA 42 and 2.6 per 100,000 in South Australia 43, affecting both genders equally and usually presenting between 25 and 60 years of age. 44 Because achalasia is a chronic condition, its prevalence greatly exceeds its incidence. A recent estimate of achalasia prevalence in Chicago concluded that it may be as high as 76 per 100,000 population, given that the average age of diagnosis was 56 with an expected average survival of 26 years after diagnosis. 42 Reports of familial clustering of achalasia raise the possibility of genetic predisposition. However, arguing against a strong genetic determinant, a survey of 1,012 first-degree relatives of 159 achalasics identified no affected relatives. There is a rare genetic achalasia syndrome associated with adrenal insufficiency in a lacrima. This syndrome is inherited as an autosomal recessive disease and manifests with the childhood onset of autonomic nervous system dysfunction including achalasia, alacrima, sinoatrial dysfunction, abnormal pupillary responses to light, and delayed gastric emptying. 45 It is caused by mutations in AAAS, which encodes a protein known as eladin. There are no population-based studies on the incidence or prevalence of esophageal motility disorders other than achalasia. Thus, the only way to estimate the incidence or prevalence of spastic disorders is to examine data on populations at risk and reference the observed frequency of spastic disorders to the incidence of achalasia, which, as detailed earlier, is about 2.75 per 100,000 population. Doing so, the prevalence of DAY is much lower than that if modern restrictive diagnostic criteria are used. Populations at risk for motility disorders are patients with chest pain and/or dysphagia, so it is among these patients that extensive manometric data have been collected. Manometric abnormalities are prevalent among these groups, but in most cases the manometric findings are of unclear significance. 46 Pathogenesis. Oropharyngeal dysphagia. Obstructing lesions of the oral cavity, head, and neck can cause dysphagia. Structural abnormalities may result from trauma, surgery, tumors, caustic injury, congenital anomalies, or acquired deformities. The most common structural abnormalities of the hypopharynx associated with dysphagia are hypopharyngeal diverticula and cricopharyngeal bars. 30 Pressure, mmHg, 5-10-15 Length along the esophagus 20-25 30-35 4490 4495 4500 Time, SEC, 4505 4510 4515 2010 010 Gastroesophageal common cavity abdominal onset of TLESR strain proximal esophageal clip SCJ clip 7.0 cm 5.0 cm 9.5 cm UES relaxation Fig 44.7 Esophageal shortening during a TLESR. Fluoroscopic visualization of movement of endoclips, one placed at the SCJ and one 10 cm proximal to the SCJ, during a TLESR is recorded in a high-resolution EPT format. The manometric recording spans the pharynx to the stomach and, in this instance, the TLESR is associated with an abdominal strain and a microburp evident by the brief UES relaxation and abrupt depressurization of the esophagus with gas venting. When the clip data are imported into the isobaric contour plot, it is evident that the SCJ clip excursion mirrors movement of the EGJ high-pressure band. Esophageal shortening is most prominent in the distal portion of the 10 cm segment isolated by the endoscopic clips, as seen from the approximately 7 cm movement of the distal SCJ clip concurrent with minimal movement of the proximal clip. Note also the absence of crural diaphragm contractions for the duration of the TLESR. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 647-44 If the etiology of oropharyngeal dysphagia is not readily apparent after an initial evaluation for anatomic disorders, evidence of functional abnormalities should be sought. Primary neurologic or muscular diseases involving the oropharynx are often associated with dysphagia. Whereas esophageal dysphagia usually results from esophageal diseases, oropharyngeal dysphagia frequently results from neurologic or muscular diseases, with oropharyngeal dysfunction being just one pathologic manifestation. Although the disease specifics vary, the net effect on swallowing can be analyzed according to the mechanical description of the swallow outlined earlier. Table 44.1 summarizes the mechanical elements of the swallow, the manifestation and consequence of dysfunction, and representative pathologic conditions in which they are likely encountered. Neurologic examination may indicate cranial nerve dysfunction, neuromuscular disease, cerebellar dysfunction, or an underlying movement disorder. Functional abnormalities can be due to dysfunction of intrinsic musculature, peripheral nerves, or central nervous system control mechanisms. Of note, contrary to popular belief, the gag reflex is not predictive of pharyngeal swallowing efficiency or aspiration risk. The gag reflex is absent in 20% to 40% of normal adults. 47 evident in Table 44.1. Oropharyngeal dysphagia is frequently the result of neurologic or muscular diseases. Neurologic diseases can damage the neural structures requisite for either the afferent or efferent limbs of the oropharyngeal swallow. Virtually any neuromuscular disease can potentially cause dysphagia, see Chapter 37. As there is nothing unique to neurons controlling swallowing, their involvement in disease processes is usually random. Furthermore, in most instances, functions mediated by adjacent neuronal structures are concurrently involved. The following discussion will focus on neuromuscular pathologic processes most commonly encountered. Stroke aspiration pneumonia has been estimated to inflict a 20% death rate in the first year after a stroke, and 10% to 15% each year thereafter. It is usually not the first episode of aspiration pneumonia, but the subsequent recurrences over the years that eventually cause death. The ultimate cause of aspiration pneumonia is dysphagia leading to aspiration that can occur by a number of mechanisms: absence or severe delay in triggering the swallow, reduced lingual control, or weakened laryngopharyngeal musculature. 7 Conceptually, these etiologies can involve motor or sensory impairments. Cortical infarcts are less likely to result in severe dysphagia than brainstem strokes. Cortical infarcts are also more likely to demonstrate recovery from dysphagia. Of 86 consecutive patients who sustained an acute cerebral infarct, 43%, experienced dysphagia when evaluated within 4 days of the event. However, 86% of these patients were able to swallow normally 2 weeks later, with recovery resulting from contralateral areas taking over the lost function. 48 Failure to recover was more likely among patients incurring larger infarcts or patients who had prior infarcts. Amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is a progressive neurologic disease characterized by degeneration of motor neurons in the brain, brainstem, and spinal cord. Specific symptoms are dependent upon the locations of affected motor neurons and the relative severity of involvement. When the degenerative process involves the cranial nerve nuclei, swallowing difficulties ensue. Oropharyngeal dysfunction characteristically begins with the tongue and progresses to involve the pharyngeal and laryngeal musculature. Patients experience choking attacks, become volume depleted or malnourished, and incur aspiration pneumonia. The decline in swallowing function is progressive and predictable, invariably leading to gastrostomy feeding. Patients often die as a consequence of their swallowing dysfunction in conjunction with respiratory depression. 49 Parkinson disease. Although only 15% to 20% of patients with Parkinson disease complain of swallowing problems, more than 95% have demonstrable defects when studied video fluoroscopically. 50 This disparity suggests that patients compensate in the early stages of the disease and complain of dysphagia only when it becomes severe. Abnormalities include repetitive lingual pumping prior to initiation of a pharyngeal swallow, piecemeal swallowing, and oral residue after the swallow. Patients may also exhibit a delayed swallow response and a weak pharyngeal contraction, resulting in vallecular and pyriform sinus residue. Recent data suggest this to be related to the combination of incomplete UES relaxation and a weakened pharyngeal contraction. 50 Vagus nerve disorders. Unilateral lesions of the vagus can result in hemiparesis of the soft palate and pharyngeal constrictors, as well as of the laryngeal musculature. The recurrent laryngeal nerves can be injured as a result of thyroid surgery, aortic aneurysms, pneumonectomy, primary mediastinal malignancies, or metastatic lesions to the mediastinum. Owing to its more extensive loop in the chest, the left recurrent laryngeal nerve is more vulnerable to involvement by mediastinal malignancy than the right laryngeal nerve. Unilateral recurrent laryngeal nerve injury results in unilateral adductor paralysis of the vocal cord. This defect can result in aspiration during swallowing because of impaired laryngeal closure. It is, however, rare to have any primary pharyngeal dysfunction resultant from recurrent laryngeal nerve injury. Oculopharyngeal muscular dystrophy. Oculopharyngeal muscular dystrophy is a syndrome characterized by ptosis and progressive dysphagia. In the past, afflicted patients reaching age 50 typically died of starvation resulting from pharyngeal paralysis. The disease is now known to be a form of muscular dystrophy and is inherited as an autosomal dominant disorder, with occurrences clustered in families of French-Canadian descent. Genetic studies of an afflicted family indicate linkage to chromosome 14, perhaps involving the region coding table 44.1 mechanical events of the oropharyngeal swallow, evidence of dysfunction, and disease association, S. In patients with oropharyngeal dysphagia, mechanical event evidence of dysfunction, disease association, S. Nasopharyngeal closure, nasopharyngeal regurgitation, nasal voice, myasthenia gravis, laryngeal closure, aspiration during bolus transit, stroke, traumatic brain injury, UES, opening, dysphagia, post-swallow residue / aspiration, diverticulum formation, cricopharyngeal bar, Parkinson disease, tongue loading and bolus propulsion, sluggish misdirected bolus, Parkinson disease, surgical defects, cerebral palsy, pharyngeal clearance, post-swallow residue in hypopharynx / aspiration, polio or post-polio syndrome, oculopharyngeal dystrophy, stroke. 648 Part V, esophagus for cardiac alpha or beta myosin heavy chains. Oculopharyngeal dystrophy affects the striated pharyngeal muscles and the levator palpebrae. Although other forms of muscular dystrophy occasionally affect the pharyngeal constrictors, this is rarely a dominant manifestation. The first symptom of oculopharyngeal dystrophy is usually ptosis that slowly progresses and eventually dominates the patient's appearance. Dysphagia may begin after, concomitant with, or even before ptosis. The dominant functional abnormalities are of a weak or absent pharyngeal contraction, reduced cricopharyngeal opening, and hypopharyngeal stasis. 51 Dysphagia is slowly progressive, but may ultimately lead to starvation, aspiration pneumonia, or asphyxia. Myasthenia gravis. Myasthenia gravis is a progressive autoimmune disease characterized by high circulating levels of ACH receptor antibody and destruction of ACH receptors at neuromuscular junctions. Musculature controlled by the cranial nerves is almost always involved, particularly the ocular muscles. Dysphagia is prominent in more than a third of patients with myasthenia gravis and, in unusual instances, can be the initial and dominant manifestation of the disease. In mild cases, dysphagia may not be evident until after 15 to 20 minutes of eating. Classically, manometric studies reveal a progressive deterioration in the amplitude of pharyngeal contractions with repeated swallows. Peristaltic amplitude recovers with rest or following the administration of 10 mg edrophonium chloride, an acetylcholinesterase inhibitor. In more advanced cases, the dysphagia can be profound and associated with nasopharyngeal regurgitation and nasality of the voice, even to the extent of being confused with bulbar amyotrophic lateral sclerosis or brainstem stroke. 52 Hypopharyngeal, Zenker, diverticula and cricopharyngeal bar. Hypopharyngeal diverticula and cricopharyngeal bars are closely related disease entities in that it is a cricopharyngeal bar that can result in diverticulum formation. The most common type, Zenker diverticulum, Fig 44.8, originates in the midline posteriorly at Killian dehiscence, a point of pharyngeal wall weakness between the oblique fibers of the inferior pharyngeal constrictor and the transverse cricopharyngeus muscle. Other locations of acquired pharyngeal diverticula include 1. The lateral slit separating the cricopharyngeus muscle from the fibers of the proximal end of the esophagus, through which the recurrent laryngeal nerve and its accompanying vessels run to supply the larynx. 2. At the penetration of the inferior thyroid artery into the hypopharynx. 3. And at the junction of the middle and inferior constrictor muscles. The unifying theme of these locations is that they are sites of potential weakness of the muscular lining of the hypopharynx through which the mucosa herniates, leading to a false diverticulum. The best substantiated explanation for the development of diverticula is that they form as a result of a restrictive myopathy associated with diminished compliance of the cricopharyngeus muscle. Surgical specimens of cricopharyngeus muscle strips from patients with hypopharyngeal diverticula demonstrated structural changes that would decrease UES compliance and opening. 53 The cricopharyngeus samples from these patients had fibroadipose tissue replacement and muscle fiber degeneration. Thus, although the muscle relaxes normally during a swallow, it cannot distend normally, resulting in the appearance of a cricopharyngeal indentation, or bar, during a barium swallow, Fig 44.9. Diminished sphincter compliance necessitates increased hypopharyngeal intrabolus pressure to maintain transsphincteric flow through the smaller UES opening. The increased stress on the hypopharynx from the increased intrabolus pressure may ultimately result in diverticulum formation. Achalasia is characterized by impaired lay relaxation with swallowing and a peristalsis in the smooth muscle esophagus. If there are premature, spastic contractions in the esophageal body, the disease is referred to as spastic, type 3, achalasia. 54 Zinker diverticulum cricopharyngeus Fig 44.8 Film from a barium swallow study showing a small Zinker diverticulum. Although the point of herniation is midline posterior at Killian dehiscence, the diverticulum migrates laterally in the neck as it enlarges, because there is no potential space between the posterior pharyngeal wall and the vertebral column. Cricopharyngeus esophagus trachea Fig 44.9 Film from a barium swallow study showing a cricopharyngeal bar in a patient with oropharyngeal dysphagia. The posterior indentation of the barium column is caused by a non-compliant cricopharyngeus muscle. Courtesy Dr. Richard Gore, Evanston, IL. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 649-44 These physiologic alterations result from damage to the innervation of the smooth muscle segment of the esophagus, including the LES, with loss of ganglion cells within the myenteric, Auerbach, plexus. Several observers report fewer ganglion cells and ganglion cells surrounded by mononuclear inflammatory cells in the smooth muscle esophagus of achalasia. 55 The degree of ganglion cell loss parallels the duration of disease, likely progressing from EGJ outflow obstruction to type 2 achalasia, to type I achalasia, to end-stage achalasia. 55,56 Type 3 achalasia seems to have a unique pathogenesis, characterized by myenteric plexus inflammation and altered function, but not destruction. 55. Physiologic studies in achalasia suggest dysfunction consistent with postganglionic denervation of esophageal smooth muscle potentially affect excitatory ganglion neurons, cholinergic, inhibitory ganglion neurons, no plus or minus VIP, or both, see Fig 44.4. Muscle strips from the circular layer of the esophageal body of achalasia contract when directly stimulated by ACH but fail to respond to ganglionic stimulation by nicotine, indicating a postganglionic excitatory defect. However, partial preservation of the postganglionic cholinergic pathway is suggested by the observations that in some cases, an achalasia's LES pressure increases after administration of the ACE inhibitor edrophonium and decreases after administration of the muscarinic antagonist atropine, crucial observations for understanding why botulinum toxin may have some therapeutic benefit, see section on treatment. Regardless of excitatory ganglion neuron impairment, it is clear that inhibitory ganglion neuron dysfunction is as an early manifestation of achalasia. These neurons mediate deglutative inhibition, including lay relaxation, and the sequenced propagation of esophageal peristalsis. Their absence offers a unifying hypothesis for the key physiologic abnormalities of achalasia, impaired lay relaxation and a peristalsis. Achalasics have been shown to lack no synthase and have a marked reduction of VIP staining neurons in the gastroesophageal junction. There is substantial evidence of impaired esophageal postganglionic inhibitory innervation in achalasics. Muscle strips from the LES do not relax in response to ganglionic stimulation by nicotine as they do in normal controls. Furthermore, CCK, which normally stimulates the inhibitory ganglion neurons and thus reduces lay pressure, paradoxically increases lay pressure in achalasia. 57 Impaired inhibitory innervation of the smooth muscle esophagus above the LES has been more difficult to demonstrate because of the absence of resting tone in this region. However, in a clever experiment, Sifram and co-workers used an intraesophageal balloon to create a high-pressure zone in the tubular esophagus that then relaxed with the onset of deglutative inhibition. This deglutative relaxation in the esophageal body was absent in early, non-dilated cases of achalasia. 58 The ultimate cause of ganglion cell degeneration in idiopathic achalasia is gradually being unraveled, with increasing evidence pointing toward an autoimmune process in genetically susceptible individuals. 59 Analysis of the myenteric plexus infiltrate in achalasia patients revealed that the majority of inflammatory cells are either resting or activated cytotoxic T cells. Antibodies against myenteric neurons have been detected in sera of achalasia patients, especially in patients with specific HLA alleles. The trigger for initiating the autoimmune response leading to the development of achalasia remains controversial, but is suspected to be a chronic or latent human herpes virus 1, HSV1, infection. 59 Interestingly, HSV1 was also detected in lay tissue from non-achalasic organ donors, suggesting that the development of achalasia is dependent on both the virus and a genetic predisposition. Distal esophageal spasm, DE. Although the diagnosis of DE is often invoked as a cause of esophageal chest pain, the entity is actually exceedingly rare, with most cases of esophageal chest pain attributable to reflux disease or achalasia. Historically, the manometric criteria for diagnosing DE have been nonspecific, leading to overdiagnosis of the entity. This has been clarified somewhat with the Chicago classification of high-resolution manometry and the adoption of reduced distal latency, DL, of peristalsis as the cardinal abnormality in DE. 60 Although DE is clearly a disorder of peristalsis, the majority of afflicted patients exhibit normal peristaltic contractions most of the time. The neuromuscular pathology responsible for DE is unknown and there are no known risk factors. The most striking reported pathologic change is of diffuse muscular hypertrophy or hyperplasia in the distal esophagus with thickening of up to 2 cm. However, there are other well-documented cases in which esophageal muscular thickening was not found at thoracotomy, and still other instances of patients with muscular thickening not associated with DE symptoms. Despite the absence of defined histopathology, physiologic evidence implicates myenteric plexus neuronal dysfunction in spasm because the latency of contraction along the smooth muscle esophagus is a function of postganglionic myenteric plexus neurons. Swallow-induced vagal impulses reach the entire smooth muscle segment of the esophagus simultaneously, and it is the balance of excitatory and inhibitory ganglionic neurons within the myenteric plexus that determine the timing of contraction at each esophageal locus. Furthermore, experimental evidence suggests heterogeneity among spasm patients, such that some primarily exhibit reduced inhibitory interneuron function, whereas in others the defect is of excess excitation. Defining DE based on the latency of the post-deglutitive contraction puts it in a pathophysiologic continuum with achalasia, consistent with documented case reports of patients undergoing this evolution. 61 Furthermore, there are marked similarities between spastic achalasia and DE because both are characterized by rapidly propagated contractions in the distal esophagus. The differentiating features of vigorous achalasia are involvement of the LES and the absence of any normal peristalsis. Hypercontractile, jackhammer, esophagus. Vigorous esophageal contractions with normal DL, defined as esophageal hypercontractility or jackhammer esophagus in the Chicago classification, can be associated with both dysphagia and chest pain. Hypercontractility is thought to be a manifestation of either excessive excitatory drive or a reactive compensation for outflow obstruction leading to myocyte hypertrophy. 62 Consistent with this, patients with hypercontractility demonstrate heightened sensitivity to cholinergic agonists such as edrophonium. Data supporting obstruction as an etiology of hypercontractility come from physiologic studies using an inflatable pressure cuff implanted around the distal esophagus of cats. 63 Small cuff inflation volumes augmented the amplitude of peristalsis, but with larger volumes there was complete disruption of the peristalsis. From a clinical perspective, the summary metric for quantifying distal esophageal contractility in HRM is the distal contractile integral, DCI. DCI values greater than 8,000 mm Hg/cm/sec represent an extreme pattern of hypercontractility, often associated with repetitive contractions, rarely seen in normal subjects and almost always associated with chest pain and dysphagia. The current version of the Chicago classification labels this condition jackhammer esophagus when two such contractions occur in a manometric study. 64,65 Absent peristalsis. Impaired peristalsis ranges from weak contractions to absent contractility as can be seen in achalasia and scleroderma. Although absent contractility is often idiopathic, achalasia and scleroderma 650 Part V esophagus serve as models that shed some light on its pathogenesis. Aganglionosis in achalasia, see Fig 44.4, and myogenic disruption in scleroderma. Ultrastructure studies in scleroderma patients have reported thickening of capillary basement membranes and atrophy or fibrosis of the esophageal smooth muscle. Hence, weak peristalsis and absent contractility can be related to either myogenic or neurogenic processes, similar to elsewhere in the GI tract. Clinical features. Dysphagia is a fundamental symptom of esophageal motility disorders. Esophageal, as opposed to oropharyngeal, dysphagia is suggested by the absence of associated aspiration, cough, nasopharyngeal regurgitation, drooling, pharyngeal residue following swallow, or co-occurring neuromuscular dysfunction, e.g., weakness, paresthesia, slurred speech. On the other hand, the associated conditions of heartburn, regurgitation, chest pain, odynophagia, or intermittent esophageal obstruction suggest esophageal dysphagia. An important limitation of the patient history in esophageal dysphagia is that a patient's identification of the location of obstruction is of limited accuracy. Specifically, a distal esophageal obstruction caused by an esophageal ring, stricture, or achalasia will often be perceived as cervical dysphagia, and patients can correctly localize distal dysfunction only 60% of the time. Because of this subjective difficulty in distinguishing proximal from distal lesions within the esophagus, an evaluation for cervical dysphagia should encompass the entire length of the esophagus. Another important consideration in patient management is that esophageal motility disorders are much less common than mechanical or inflammatory etiologies of dysphagia, such as tumors, strictures, rings, or esophagitis, be that peptic, pill-induced, eosinophilic, or infectious. Historical points suggestive of a motor disorder are difficulty with both solids and liquids, as opposed to only with solids, which is more suggestive of mechanical obstruction. However, the functional consequences of mechanical or inflammatory disorders can exactly mimic those of primary motility disorders. Thus, as with the evaluation of oropharyngeal dysphagia, a motility disorder should be considered as an etiology for esophageal dysphagia only after exclusion of more common diagnoses by endoscopic, histologic, and/or radiographic examination. Achalasia. Clinical manifestations of achalasia may include dysphagia, regurgitation, chest pain, hiccups, halitosis, weight loss, and aspiration pneumonia. All patients have solid food dysphagia. The majority of patients also have variable degrees of liquid dysphagia. The onset of dysphagia is usually gradual, and often present for years at the time of presentation. The severity of dysphagia fluctuates but eventually plateaus. With long-standing disease, there is progressive esophageal dilatation, and regurgitation becomes frequent with recumbency. The regurgitant is often recognized as food that has been eaten hours, or even days, previously. It tends to be non-bilious, non-acid, and mixed with copious amounts of saliva. Patients often fail to recognize the slimy mucoid regurgitant as saliva, being unfamiliar with its visual consistency. Chest pain is a complaint early in the course of achalasia in approximately 2/3 of patients. Its etiology is unknown, but is thought to be related to the occurrence of esophageal spasm, more recently, proposed to be spasm of longitudinal muscle. Treatment of achalasia is less effective in relieving chest pain than it is in relieving dysphagia or regurgitation. However, unlike dysphagia or regurgitation, chest pain may spontaneously improve or disappear over time. With advanced achalasia, up to 10% of cases have bronchopulmonary complications as a result of regurgitation and aspiration. In some instances, it is these complications rather than dysphagia that prompts them to seek medical care. Another interesting, but fortunately rare, symptom of achalasia is airway compromise and stridor as a result of the dilated esophagus compressing the membranous trachea in the neck. This is hypothesized to occur because the neuromuscular apparatus facilitating UES relaxation as part of the belch reflex is compromised. 66 It is paradoxical that many achalasics complain of heartburn even after the onset of dysphagia. Although reflux may be a common sequela of the treatments for achalasia, it seems physiologically inconsistent to simultaneously have dysphagia from impaired lay relaxation and reflux from excessive lay relaxation. In support of this skepticism, ambulatory 24-hour esophageal pH studies of achalasics have only shown periods of esophageal acidification caused by the bacterial fermentation of retained food in the esophagus, rather than discrete gastroesophageal reflux events. 67 Furthermore, it is highly unusual for an achalasic to have a TLESR. Rather, they usually exhibit incomplete TLESRs with crural inhibition, esophageal shortening, and a profound after-contraction, but devoid of the less relaxation element. 68 Distal esophageal spasm. The major symptoms of DE are dysphagia and chest pain. Weight loss is rare. Dysphagia is usually intermittent and sometimes related to swallowing specific substances such as red wine or liquids at extreme hot or cold temperature. In some instances, patients experience episodes of esophageal obstruction while eating that persists until relieved by emesis. Esophageal chest pain is very similar in character to angina, often described as crushing or squeezing in character, radiating to the neck, jaw, arms, or midline of the back. Pain episodes may last from minutes to hours, but continued swallowing is not always impaired. The mechanism producing esophageal pain is poorly understood. High-frequency intraluminal ultrasound data suggest that it may be related to sustained contraction of esophageal longitudinal muscle. 69 Chest pain is also prevalent in patients subsequently found to have manometric abnormalities that are insufficient to establish a diagnosis of achalasia or DE. Among such individuals, there is a high prevalence of reflux and of psychiatric diagnoses, particularly anxiety and depression. 46 Hypercontractile esophagus. The hypercontractile disorders also typically present with chest pain and dysphagia, although the dysphagia is less likely to involve impaired bolus transit. By definition, contractile latency is normal with hypercontractility, hence, peristaltic progression and bolus transit are normal. However, the jackhammer pattern is associated with prolonged repetitive contractions that can persist long after bolus transit, Fig. 44.10b. The natural history of hypercontractility is unknown, but it is clear that at least in some cases jackhammer patients can have a prolonged and difficult clinical course. Absent contractility patients with absent peristalsis can present with dysphagia or symptoms suggestive of severe GERD, such as heartburn, regurgitation, and chest pain. The severity of the presentation is to some degree dependent on the function of the EGJ. GERD symptoms are much worse when absent peristalsis is accompanied by gross EGJ incompetence. Alternatively, with an intact EGJ, absent peristalsis may be difficult to distinguish from achalasia, owing to the similar symptomatology and physiologic findings. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 651 44 Differential diagnosis. The patient history is crucial in the evaluation of dysphagia. Major objectives of the history are to differentiate oropharyngeal dysphagia from esophageal dysphagia, xerostomia, hyposalivation, or globus sensation. All are frequently confused with each other. Globus sensation, in particular, is frequently confused with dysphagia. Unlike dysphagia, which occurs only during swallowing, globus sensation is prominent between swallows. Patients relate the nearly constant sensation of having a lump in their throat or feeling a foreign object caught in their throat. In some instances globus is associated with reflux symptoms, and in others with substantial anxiety. It is the linkage with anxiety that led to the older nomenclature globus hystericus. Unfortunately, studies have failed to define an objective anatomic or physiologic cause for globus, and we are left with the crucial data being in the history. Globus sensation persists regardless of the act of swallowing. Achalasia. The differential diagnosis of achalasia includes other esophageal motility disorders and diseases of distinct pathophysiology that duplicate the functional consequences of achalasia. With respect to other motility disorders, there are many similarities between DE and achalasia, especially the subtype of spastic achalasia. In fact, the only distinction between these entities is the demonstration of incomplete lay relaxation in type 3 achalasia, and there are case reports of DE evolving into spastic achalasia. 61 However, Given the rarity of both conditions and the historical heterogeneity on how they are diagnosed, it seems likely that only a small minority of achalasia cases are part of a continuum with DA. With respect to other diseases that duplicate the functional consequences of idiopathic achalasia, the main considerations are Chagas disease and pseudoachalasia that is associated with infiltrative diseases, malignancy, obstruction, or surgery. Chagas disease. Esophageal involvement in Chagas disease, which is endemic in areas of central Brazil, Venezuela, and northern Argentina, can be indistinguishable from idiopathic achalasia. An estimated 20 million South Americans are infected. Due to immigration, about 500,000 people in the USA are believed infected. Chagas disease is spread by the bite of a reduvid, kissing, bug that transmits the parasitic protozoan, Trypanosoma cruzi. An acute septicemic phase of the illness follows that varies in severity from going unnoticed to being fatal. The chronic phase of the disease develops up to 20 years after infection and results from destruction of autonomic ganglion cells throughout the body, including the heart, gut, urinary tract, and respiratory tract. Chronic cardiomyopathy with conduction system disturbances and arrhythmias is the most common cause of death. Within the digestive tract, the organs most commonly affected are the esophagus, duodenum, and colon. The severity of esophageal dysfunction is directly proportional to the degree of intramural ganglion cell loss. Abnormal peristalsis is first detectable after 50% of ganglion cells are destroyed, and esophageal dilatation after 90% are destroyed. Paralleling this, the initial dysfunction is confined to the esophageal body, with lay dysfunction occurring late in the course of the disease. The most obvious clinical distinction between idiopathic achalasia and esophageal involvement in Chagas disease is evidence of additional tubular organ involvement, cardiomyopathy, megaduodenum, megacolon, megarectum, megaureter. In Chagas disease. 70 With respect to esophageal pathology, the two are otherwise indistinguishable. The diagnosis of Chagas disease is made in the acute phase by visualizing the parasite in a blood smear. In the chronic phase, the diagnosis is confirmed by serologic tests using complement fixation or PCR. The treatment of the achalasia syndrome in Chagas disease is similar to that for idiopathic achalasia. Treatment of the infection itself is of limited efficacy in the acute phase and of no proved efficacy with chronic disease. A. Normal. B. Hypercontractile jackhammer time, SEC, 10 length along the esophagus, cm, 30 35 5 15 1 20 25 150 0 150 mmHg 30 time, SEC, 10 SEC 10 SEC DCI equals 3212 mm Hg, SEC, cm DCI equals 6508 mm Hg, SEC, cm DCI equals 20,452 mm Hg, SEC, cm Fig 44.10 Normal and abnormal contractile vigor. A normal swallow with a distal contractile interval, DCI, of 3,212 mm Hg SEC cm, normal propagation and a single uniform contraction. B. Swallow with an extremely high DCI. This swallow exhibits repetitive contractions without evidence of an EGJ outflow obstruction. This is a hypercontractile or jackhammer pattern in the Chicago classification, see Table 44.2. With permission from the Esophageal Center at Northwestern. 652 Part V. Esophagus pseudoachalasia. Neither the radiographic nor the manometric features of achalasia are specific for idiopathic achalasia or achalasia associated with Chagas disease. Tumor-related pseudoachalasia, most commonly of the gastric cardia, accounts for up to 5% of cases with manometrically defined achalasia. Pseudoachalasia becomes more likely than idiopathic achalasia with advanced age, greater than 50 years, abrupt and recent onset of symptoms, 1 year, and early weight loss in excess of 7 kg. 44 However, even though these criteria make pseudoachalasia more likely, they still have poor predictive value in the individual case. It is because of this potential pitfall that a thorough anatomic examination, including endoscopy, should be done as part of the diagnostic evaluation of every new case of achalasia. More than the slightest resistance of passage of the endoscope across the EGJ can be a clue to the presence of pseudoachalasia. In idiopathic achalasia, the endoscope should pop through with only gentle pressure required. If suspicion of pseudoachalasia is high, endoscopic biopsy, CT, MRI, or EUS should be considered for further evaluation, depending upon the individual circumstances. Adenocarcinoma of the EGJ accounts for more than half of tumor-associated pseudoachalasia cases, with a myriad of tumors, pancreatic, hepatocellular, prostatic, lung, esophageal, and lymphoma, accounting for the remainder. 44 These tumors produce an achalasia syndrome by infiltrating the wall of the esophagus at the EGJ, causing a malignant obstruction at the LES, with proximal esophageal dilatation. Similarly, pseudoachalasia can result from esophageal wall stiffness from an infiltrating disease, eosinophilic esophagitis, sarcoidosis, vascular obstruction, abdominal obesity, opiate effect, or surgery-related obstruction, as discussed later. 71 Although often discussed in the literature, it is much less common that an achalasic syndrome occurs as a paraneoplastic syndrome without direct tumor involvement of the EGJ. Post-surgical dysfunction dysphagia is common in the early period following fundoplication, and patients are advised to consume soft diets for the first 2 to 4 postoperative weeks. Dysphagia that persists longer than 4 weeks should be evaluated with an upper endoscopy or barium esophagogram to assess the integrity of the wrap and evaluate for possible paraesophageal hernia. Subjects without an overt mechanical disruption should be evaluated with manometry to assess peristaltic function, EGJ relaxation, and esophageal pressurization to determine whether the wrap is too tight or an underlying motility disorder, such as achalasia, exists. Diagnosing achalasia in the context of fundoplication can be difficult because the key manometric findings, upper peristalsis and impaired EGJ relaxation, can be identical. Bariatric surgery, especially laparoscopic adjustable gastric banding, can also be complicated by development of a pseudoachalasia syndrome. A surgical report examined 121 patients 1 year post-procedure and found 14% of them to have esophageal dilatation in excess of 3.5 cm. Affected patients developed an achalasia-type syndrome with dysphagia and vomiting. 72 This form of pseudoachalasia is usually, but not always, reversible with removal of the gastric band. 73 Distal esophageal spasm. The pain associated with DA can closely mimic that of angina pectoris. Given the potentially fatal consequences of myocardial ischemia, this must always be considered carefully in the differential diagnosis. Features suggesting an esophageal, as opposed to a cardiac, etiology of pain include 1. Prolonged non-exertional pain, 2. Pain that interrupts sleep, 3. Meal-related pain, 4. Relief with antacids, and 5. Additional accompanying esophageal symptoms, such as heartburn, dysphagia, or regurgitation. However, even these features can exhibit overlap with cardiac pain. Furthermore, even within the spectrum of esophageal diseases, neither chest pain nor dysphagia is specific for DA. Both symptoms are also characteristic of common esophageal disorders including peptic or infectious esophagitis. Hence, only after these more common diagnostic possibilities have been excluded by appropriate radiographic evaluation, endoscopic evaluation, and a therapeutic trial of PPIs, should DA be considered. Diagnostic methods. Endoscopy. Upper endoscopy should be the first test for evaluating new-onset dysphagia, because it combines the ability to detect most structural causes of dysphagia with the ability to obtain biopsies. The increasing recognition of eosinophilic esophagitis, see Chapter 30, as a confounding clinical entity has increased the potential value of biopsies when performing upper endoscopy in the evaluation of dysphagia. The endoscopist should have a very low threshold for obtaining multiple esophageal mucosal biopsy specimens to evaluate for eosinophilic esophagitis in patients with dysphagia, even in patients with a normal-appearing esophageal mucosa. Additionally, should a stricture or mucosal ring be detected, dilation can be accomplished in the same endoscopic session. However, even though upper endoscopy is an excellent tool for evaluating dysphagia, it has substantial limitations in assessing extraluminal structures and abnormal esophageal motility. It also has the potential to miss subtle obstructing lesions such as webs and rings. Contrast imaging contrast studies of the oropharynx and esophagus are useful in assessing dysphagia if endoscopy is inconclusive. Video fluoroscopy is particularly useful for a functional evaluation of the oropharyngeal phase of swallowing following an exam for anatomic explanations. Frequently referred to as a modified barium swallow, Logeman has described a protocol comprising a series of swallow tasks. 7 images are obtained in a lateral projection, framed to include the oropharynx, palate, proximal esophagus, and proximal airway. These images are then evaluated with respect to 4 major categories of oropharyngeal dysfunction: 1. Inability or excessive delay in initiation of pharyngeal swallowing, 2. Aspiration, 3. Nasopharyngeal regurgitation, and 4. Residue of the ingustate within the pharyngeal cavity after swallowing. Furthermore, the procedure allows for evaluation of the efficacy of various compensatory dietary modifications, postures, and swallowing maneuvers in compensating for observed swallowing dysfunction. A barium esophagogram can also provide critical information regarding UES function, peristalsis, and bolus clearance through the EGJ. With advanced cases of achalasia, Fig 44.11, the findings are somewhat obvious, and it is only necessary clinically to differentiate between primary and secondary etiologies. However, with good technique, normal peristalsis can also be verified. Peristalsis is best evaluated in the prone position so that clearance does not occur by gravity. 44 Peristaltic abnormalities are inferred by retrograde escape of the bolus through the peristaltic wave front, resulting in incomplete esophageal emptying. Normally the EGJ will become widely patent when the bolus reaches this area, and impaired relaxation can be inferred when either a smooth tapering is noted at the EGJ or bolus transit across the EGJ is impeded. Alternatively, fluoroscopy will occasionally demonstrate spastic contractions, evident by a corkscrew appearance, Fig 44.12. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 653 44 High Resolution Manometry, HRM. Esophageal manometry is a test in which intraluminal pressure sensors are positioned within the esophagus to measure the contractile characteristics of the esophagus and segregate it into functional regions. The concept of high-resolution esophageal manometry is to use a sufficient number of pressure sensors within the esophagus such that intraluminal pressure can be monitored as a continuum along the length of the esophagus, much as time is viewed as a continuum in line tracings of conventional manometry, such as those in Fig 44.3. When HRM is coupled with sophisticated algorithms to display the manometric data as pressure topography plots, esophageal contractility is visualized with isobaric conditions among sensors indicated by isocholoric regions on the pressure topography plots. Fig 44.3 depicts a normal swallow in a pressure topography plot encompassing both sphincters and the intervening esophagus. The relative timing of sphincter relaxation and segmental contraction as well as the position of the transition zone are all readily demonstrated. Given the major advances in our understanding of HRM over the last 15 years, a new classification was developed using the improved accuracy and detail of the new technology. The Chicago classification of esophageal motor disorders was vetted and periodically updated by a group of international experts with the most recent version, 3.0, published in 2015.64. The Chicago classification incorporates standardized metrics to quantify EGJ relaxation, integrated relaxation pressure IRP, and peristalsis, DCI, DL, into an algorithm to generate 4 broad categories of function: 1. Disorders with EGJ outflow obstruction, 2. Major disorders of peristalsis, 3. Minor disorders of peristalsis, and 4. Normal. Fig 44.13.64 The manometric evaluation of deglutative EGJ relaxation is probably the most important measurement made during clinical esophageal manometry. Incomplete EGJ relaxation is an essential feature in the diagnosis of achalasia, and achalasia is the motor disorder with the most specific treatments. Despite this cardinal significance, there was no convention for defining incomplete deglutative EGJ relaxation prior to the Chicago classification. Key to the development of the Chicago classification was a study comparing criteria for detecting impaired deglutative EGJ relaxation in a large group of patients and control subjects, resulting in the development of the IRP, with normal being 15 mm Hg or less, with the manometric device used in that analysis 0.74. Conceptually, the IRP is the average EGJ pressure for the 4 seconds of greatest relaxation within the 10-second period after a swallow, see Fig. 44.6. This single measure of deglutative EGJ relaxation exhibited 98% sensitivity and 96% specificity for distinguishing well-defined achalasia patients from control subjects and patients with other diagnoses. 0.74. Apart from improving the sensitivity of manometry in the detection of achalasia, HRM has also defined a clinically relevant subclassification of achalasia. 0.54. A diagnosis of achalasia requires both absent peristalsis and impaired deglutative EGJ relaxation. In its most obvious form, type I, this occurs in the setting of esophageal dilatation with negligible pressurization within the esophagus, Fig. 44.14a. However, despite there being no peristalsis, there can still be substantial pressurization within the esophagus. In fact, the most common pattern, type 2, encountered is achalasia with esophageal compression and pansophageal pressurization, see Fig. 44.14b. The other, less common, pattern, type 3, is spastic achalasia, where there is a spastic contraction within the distal esophageal segment, see Fig. 44.14c. Several subsequent series, including a follow-up report on the European randomized controlled trial comparing laparoscopic Heller myotomy to pneumatic dilation 75, have Fig. 44.11 films from barium swallow studies in the 3 subtypes of idiopathic achalasia, see Table 44.2. Note esophageal dilatation with air fluid levels, left and center panels, and the tapering at the EGJ. Radiologic findings can be much more subtle in the early phases of the disease. The film in the right was taken during a timed barium esophagram, indicating that barium was still retained within the dilated esophagus at 5 minutes. Type I, Type 2, Type 3 air EGJ contraction diverticulum. Fig. 44.12 barium esophagogram showing a corkscrew esophagus in a patient with symptomatic day. 654. Part V esophagus achalasia. Type I, no contractility. Type 2, greater than or equal to 20% PEP. Type 3, greater than or equal to 20% spasm, DL 4.5 SEC, EGJ outflow obstruction. Incomplete achalasia mechanical obstruction. Distal esophageal spasm greater than or equal to 20% premature, DL 4.5 SEC, jackhammer esophagus greater than or equal to 20% DCI greater than 8000 mmHg SECCM. Absent contractility, no scorable contraction. Consider achalasia. Ineffective motility, IEM, 50% ineffective swallows. Fragmented peristalsis, 50% fragmented swallows and not ineffective. Disorders with EGJ outflow obstruction. 1 2 no yes 3 4 5 IRP greater than or equal to ULN and 100% failed peristalsis or spasm. IRP greater than or equal to ULN and not. Type I3 achalasia. IRP normal and low DL or high DCI or 100% failed peristalsis. IRP normal and 50% ineffective swallows. IRP normal and 40% effective swallows. Major disorders of peristalsis. Entities not seen in normal subjects. Minor disorders of peristalsis. Impaired clearance. Normal. Fig. 44.13 algorithm for applying the Chicago classification of esophageal motor disorders. DCI, distal contractile interval, DL, distal latency, EGJ, esophagogastric junction, IBC, isobar contour, IRP, integrated relaxation pressure, PEP, pansophageal pressurization, ULN, upper limit of normal. See Table 44.2 for more detail. 150 mmHg 30 Type I Type 2 Type 3 IRP equals 22.3 mm Hg IRP equals 24.2 mm Hg IRP equals 29.8 mm Hg Air Liquid 5 SEC 5 SEC 5 SEC Fig 44.14 Achalasia Subtypes. The three subtypes are distinguished by distinct manometric patterns of esophageal body contractility. In the patient with classic achalasia, type I, there is no significant pressurization within the body of the esophagus and EGJ relaxation is impaired, IRP 22.3 mm Hg in this example. A swallow from a type 2 patient, the achalasia with compression subtype, shows rapid panesophageal pressurization of the fluid column trapped between the sphincters as the esophagus shortens. The pressure topography plot in the type 3 patient is typical of spastic achalasia. Although this swallow is also associated with rapidly propagated pressurization, the pressurization is attributable to an abnormal lumen obliterating contraction. Modified from Pandolfino J.E., Kwiatek Ma, Neelis T., ETAL achalasia, a new clinically relevant classification by high-resolution manometry. Gastroenterology 2008. 135:1526-33. With permission from the Esophageal Center at Northwestern. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 655-44 confirmed the initial observation of that seminal study, that type 2 achalasia is the most responsive to treatment and type 3 the least responsive. Patients with impaired EGJ relaxation, defined by an abnormal IRP with persistent peristaltic activity failing to meet diagnostic criteria for achalasia, are categorized as having EGJ outflow obstruction in the Chicago classification. 64 From the outset, these were recognized to be a heterogeneous group of patients, only some of whom benefited from achalasia treatments. 76 Two representative examples of EGJ outflow obstruction are illustrated in Fig 44.15. Hence, in some cases, such as in Fig 44.15a, this may be a variant or early presentation of achalasia. However, recent series have reported that many patients with EGJ outflow obstruction were minimally symptomatic or even asymptomatic, that in 20% to 40% of cases the disorder resolved spontaneously, and that only 12% to 40% end up being treated as achalasia. 77,78 Following the analysis of EGJ relaxation, quantitative features of the distal contraction are analyzed to identify disorders of peristalsis. This analysis is largely based on the DCI and DL, metrics based on key topographic landmarks, the onset of UES relaxation, the first pressure trough, transition zone, and the CDP. See Fig 44.3. The CDP approximates the proximal margin of the LES and is identified as the inflection point along the 30 mm Hg isobaric contour where deceleration occurs, signifying the transition from peristalsis to the ampullary emptying. 16 The interval between UES relaxation and the CDP defines the DL of the contraction, as illustrated in Fig 44.3. DL values of less than 4.5 seconds define premature contractions, likely indicative of impaired inhibitory neuronal control to define failed contractions, DCI 100 mm Hg SECCM, weak contractions, DCI 450 mm Hg SECCM, and hypercontractility, DCI 8000 mm Hg SECCM. Following analysis of individual swallows by the criteria outlined earlier, the component results are synthesized into a global manometric diagnosis by the criteria detailed in Table 44.2. Patients with normal EGJ relaxation, normal integrity, normal DL, normal contractile front velocity, and a DCI less than 5000 mmHg SECCM are normal. The abnormalities encountered are described in specific functional terms, with the intent that these then be interpreted within the clinical context. The classification detailed in Table 44.2 represents the current Chicago classification version vetted with a consensus approach by the International HRM Working Group. 64 Intraluminal impedance measurement. Intraluminal impedance monitoring was described more than a decade ago as a method to assess intraluminal bolus transit without using fluoroscopy. The technique uses an intraluminal catheter with multiple, closely spaced pairs of metal rings. An alternating current is applied across each pair of adjacent rings, and the resultant current flow between the rings is dependent on the impedance of the tissue and luminal content between the rings. Impedance decreases when the electrodes are bridged by liquid and increases when they are surrounded by air. Hence, data Fig 44.15 EGJ outflow obstruction. The criteria for EGJ outflow obstruction are an elevated IRP associated with some preserved weak or normal peristalsis, thereby not meeting the diagnostic criteria for types I, II, or III achalasia. Ultimately, this pattern may prove to be a phenotype of achalasia, as in panel A, top. This patient, who also had a large epiphrenic diverticulum, panel A, bottom, was treated with a laparoscopic myotomy and diverticulectomy with good result. Alternatively, EGJ outflow obstruction pattern can be associated with mechanical obstruction, panel B. This patient had a patulous EGJ and a 9 mm endoscope passed with no resistance noted. However, the IRP was increased, and there was compartmentalized pressurization between the preserved peristaltic contraction and the EGJ, panel B, top. The esophagogram, panel B, bottom, revealed a subtle stenosis just proximal to the EGJ, arrow, where passage of a 12.5 mm barium tablet was delayed. The patient responded to 18 mm balloon dilation and therapy with a PPI. With permission from the Esophageal Center at Northwestern. 150-150 mm Hg30A, EGJ outflow obstruction, achalasia phenotype IRP equals 22.3 mm Hg IRP equals 27.2 mm Hg barium tablet localized 12 mm restriction EGJ large diverticulum 4 cm above EGJ locus of diverticulum above EGJ-B, EGJ outflow obstruction, obstructing stricture compartmentalized pressurization normal peristalsis 656 Part V esophagus from multiple impedance segments reveals the direction, content, and completeness of bolus transit. Validation data suggest that liquid bolus entry at the level of an electrode pair is indicated by a 50% drop in impedance. Return of the impedance tracing to 50% of baseline correlates with the passage of the tail of the bolus on fluoroscopy, also indicated by the contractile upstroke noted during manometry. Validation studies against video fluoroscopy have shown excellent concordance in ascertaining bolus transit. Intraluminal impedance measurement has also recently been combined with manometry to assess the efficacy of esophageal emptying. With diminishing peristaltic amplitudes, the efficacy of emptying decreases. Currently, the main utility for combined HRM and impedance is in the assessment of esophageal transit abnormalities, particularly rumination and supragastric belching, and to assess the severity of esophageal retention in achalasia. 79 Sensory testing. Esophageal sensory nerves play a key role in determining symptoms of esophageal motor diseases, because the esophagus is sensitive to a variety of stimuli including mechanical, elicited by luminal distension or high-amplitude contractions, chemical, acid and/or other constituents of reflux, and temperature. 31 Typically, the visceral input is not perceived consciously, although some patients may experience symptoms attributed to hyperalgesia, exaggerated pain perception, or allodynia, perception of pain to a stimulus that is usually not painful. 32 Esophageal symptoms may be described as burning, pressing, pricking, or heat sensations. However, symptoms are not specific to a given stimulus, and substantial overlap in perception among stimuli is common. Although the precise mechanism by which an esophageal stimulus causes pain or the perception of dysphagia is unclear, methodologies devised to evoke or stimulate pain by simulating physiologic events are available to assess the possible relationship between ongoing symptoms and suspected causes. These tests typically use forms of distension studies, balloon, barostat, impedance planimetry or volume challenges, or direct mucosal stimulation, chemical, electrical, or thermal. Balloon distension studies have shown that esophageal distension can provoke chest pain and that patients with esophageal chest pain tend to have lower pain thresholds compared to controls. 31 The standard test of chemosensitivity is the Bernstein test, wherein 0.1 NaCl is perfused in the esophagus to reproduce chest pain or heartburn. Typically, acid infusion is alternated with saline perfusion in a blinded fashion to increase the objectivity of the test, but no standardized protocol exists. Beyond the Bernstein test, newer probes have been devised to test esophageal responsiveness to thermal challenges and transmucosal electrical nerve stimulation. However, although these tools have unquestionably been useful in improving our understanding of the interaction between peripheral receptors and central pain perception, their clinical utility remains limited owing to the lack of protocol standardization and the somewhat cumbersome nature of the studies. Currently, use of these devices is limited to specialty centers, and further refinement will be required before mainstream clinical use can be advocated. Treatment oropharyngeal dysphagia. Management of oropharyngeal dysphagia is focused on 4 specific issues: 1. Identification of an underlying disease, 2. Characterization of a disorder amenable to surgery or dilation, 3. Identification of specific patterns of dysphagia amenable to swallowing therapy, and 4. Assessment of aspiration risk. Identification of the underlying disease. A potential outcome of the evaluation is the identification of an underlying neuromuscular, neoplastic, or metabolic disorder that dictates specific management. For example, dysphagia can be the presenting symptom in patients with myopathy, myasthenia, thyrotoxicosis, motor neuron disease, or Parkinson disease. Whether or not treatment of the underlying disorder improves swallowing function depends on both the natural history of the specific disease and whether or not effective treatment exists. Disorders amenable to surgery. The most common surgical treatment for oropharyngeal dysphagia is cricopharyngeal myotomy, but the efficacy of myotomy in neurogenic or myogenic dysphagia is variable. Most series evaluating the efficacy of myotomy in these circumstances are uncontrolled and lack validated, or even specific, outcome measures. Thus, although an overall favorable response rate in excess of 60% is reported in this literature, there are no validated criteria for patient selection. Theoretically, the functional limitation faced by patients with neurogenic or myogenic dysphagia is of weak pharyngeal propulsion, and the potential benefit of myotomy is that circumstance is less obvious than in the case of obstruction at the level of the cricopharyngeus. Table 44.2 Chicago Classification v3.0 of Esophageal Motility Disorders. Diagnosis. Diagnostic criteria. Achalasia type I, classic, 100% failed peristalsis, IRPULN type 2, with esophageal compression, 100% failed peristalsis and pansophageal pressurization with greater than or equal to 20% of swallows, mean IRPULN type 3, spastic, no normal peristalsis, premature contractions with greater than or equal to 20% of swallows, mean IRPULN EGJ outflow obstruction, mean IRP greater than or equal to ULN, sufficient evidence of peristalsis such that criteria for achalasia are not met. Major disorders of peristalsis, patterns not observed in normal individuals, de mean IRPULN, greater than or equal to 20% premature contractions with DCI greater than 450 mmHg SECCM, some normal peristalsis may be present. Hypercontractile, jackhammer, esophagus at least 2 swallows with DCI greater than 8000 mmHg SECCM, may involve or even localize to the less absent contractility, mean IRP less than or equal to 10 mmHg, 100% absent contractility, DCI 100 mm Hg SECCM, minor disorders of peristalsis. Defined by exceeding statistical limits of normal, ineffective esophageal motility greater than or equal to 50%, ineffective swallows with DCI 450 mm Hg SECCM, frequent failed peristalsis 30%, but 100% of swallows with failed peristalsis, fragmented peristalsis greater than or equal to 50%, fragmented contractions with DCI greater than 450 mmHg SECCM, normal not achieving any of the above diagnostic criteria. DCI, distal contractile interval, DL, distal latency, EGJ, Esophagogastric junction, IRP, integrated relaxation pressure, see text. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 657 44 Patterns of Oropharyngeal Dysphagia Amenable to Swallow Therapy. Identifying potential treatments for oropharyngeal dysphagia begins with definition of the aberrant physiology, as categorized in Table 44.1. This is best accomplished with a video fluoroscopic swallowing study that first characterizes a patient's swallow dysfunction and then proceeds to test the effectiveness of selected compensatory or therapeutic treatment strategies. Compensatory treatments include postural changes, modifying food delivery or consistency, or the use of prosthetics. For instance, head turning can eliminate aspiration or pharyngeal residue by favoring the more functional side in patients with hemiparesis. 7 Similarly, diet modifications can reduce the difficulty of the swallow. Therapeutic strategies are designed to alter the physiology of the swallow, usually by improving the range of motion of oral or pharyngeal structures to the extent that that is possible using volitional control. Depending on the severity of the impairment, the level of motivation, and the global neurologic integrity, defective elements of the swallow can be selectively rehabilitated. For a detailed description of the techniques and limitations of swallow therapy, the reader is referred to treatises on the topic. 7,80 Evaluating aspiration risk. Oropharyngeal dysphagia is responsible for many thousands of deaths per year due to aspiration pneumonia. Video fluoroscopy is considered the most sensitive test for detecting aspiration, reportedly detecting instances not evident by bedside evaluation in about 50% of patients. However, despite the logical association between deglutitive aspiration and the subsequent development of pneumonia, this sequence is not inevitable. Nonetheless, the balance of evidence suggests that detection of aspiration is a predictor of pneumonia risk, and that its detection dictates that compensatory swallowing strategies, non-oral feeding, or corrective surgery be instituted. Whether non-oral feeding eliminates the risk of aspiration is controversial, an issue raised by the provocative finding that among patients with radiographic aspiration, pneumonia, and death were more frequent among patients who received feeding tubes. This suggests that aspiration of oral secretions may be essential in controlling pneumonia risk and has led some to consider procedures such as tracheostomy to protect the airway. Hypopharyngeal, Zenker, diverticula and cricopharyngeal bar. The treatment of hypopharyngeal diverticula is cricopharyngeal myotomy with or without a diverticulectomy or diverticulopexy. Cricopharyngeal myotomy reduces both the resting sphincter tone and resistance to flow across the UES. Good or excellent results are reported in 80% to 100% of Zenker patients treated by transcervical myotomy combined with diverticulectomy or diverticulopexy. There are instances in which a limited procedure would be adequate, but a definitive approach to the problem of pulsion diverticula should involve both diverticulectomy and myotomy. Diverticulectomy alone risks recurrence because the underlying stenosis at the level of the cricopharyngeus is not remedied. 80 Similarly, myotomy alone risks not solving the problem of food accumulation within the diverticulum, with attendant regurgitation and aspiration. Small diverticula may, however, disappear spontaneously following myotomy. A more recent trend is to treat Zenker diverticula via either rigid or flexible endoscopy. With both techniques, the principle is to divide the septum between the lumen of the diverticulum and the lumen of the esophagus. The division allows food and liquid to flow out of the diverticulum distal to the cricopharyngeus, which was within the septum, rather than to accumulate within the diverticulum. This procedure is achieved under general anesthesia, with a stapling device in the case of rigid endoscopy and under light sedation with a needle knife, argon plasma coagulation, or hot biopsy forceps in the case of flexible endoscopy. Controlled trials have not been done comparing the various procedures, but numerous case series suggest that each of them can be efficacious in skilled hands. 81 Whether or not a cricopharyngeal bar in the absence of a Zenker diverticulum requires treatment is less clear. Certainly, if dysphagia exists and combined fluoroscopic/manometric analysis demonstrates reduced sphincter opening in conjunction with an elevated upstream intrabolus pressure, there is good rationale for treatment. One uncontrolled series suggests that in patients with symptomatic bars, Dilation with a large caliber bougie may be efficacious in relieving dysphagia, a reasonable treatment option prior to myotomy. 82 Achalasia. Because the underlying neuropathology of achalasia cannot be corrected, the objectives of treatment are compensating for the poor esophageal emptying and preventing complications. In practical terms, this amounts to reducing lay pressures so that gravity along with whatever residual esophageal contractility exists promotes esophageal emptying. Lay pressure can be reduced by pharmacologic therapy, forceful dilation, or surgical myotomy. Pharmacologic treatments, on the whole, are not very effective, making them most appropriate as temporizing maneuvers. HRM allows the subtyping of achalasia into 3 distinct patterns: I. Classic achalasia, 2. Achalasia with compression, and 3. Spastic achalasia, see Fig 44.14. From a conceptual vantage point, types I and II represent a continuum, with type 2 being early disease before the progression of esophageal dilatation characteristic of type I. Type 3, on the other hand, is a subtype characterized by spasm of the distal esophagus. The significance of these disease subtypes is in how differently they responded to therapy. Until recent years, the durable treatment options for achalasia were laparoscopic Heller myotomy or pneumatic dilation. An extensive literature has compared these treatments, culminating in a multi-center European randomized controlled trial, which concluded that both approaches were about 90% effective with no statistically significant difference between them. 83,84 However, that, and all preceding trials, did not consider achalasia subtype in their design or in their assessment of treatment efficacy. Subsequently, a substantial amount of retrospective data and a reassessment of the European achalasia TRIAL 85 suggest that achalasia subtype is of great relevance in determining treatment effectiveness. Indeed, in the European achalasia trial, the efficacy of pneumatic dilation for treating type 2 achalasia was 100%, compared to only 93% for Heller myotomy, p equals 0.03. In contrast, treatment success in type 3 achalasia was achieved in 40% and 86% of patients for pneumatic dilation and laparoscopic myotomy, respectively, although the numbers were small and this difference was not statistically significant. Considering the low cost of pneumatic dilation compared to laparoscopic myotomy and that the risk of esophageal perforation between techniques is comparable, about 1%, 86 These findings argue for pneumatic dilation as the preferred initial treatment for type 2 achalasia. The bulk of the literature pertinent to achalasia treatment is composed of uncontrolled case series using a variety of qualitative endpoints as indications of efficacy. As already noted, there has been minimal standardization as to the criteria for defining achalasia, disease severity, or the technical details of how the treatments are performed. Furthermore, some series were collected prospectively, some retrospectively, and some a combination. Given all of these limitations, there is little merit to embarking on a detailed comparison of outcomes among techniques. The existing treatment data can be summarized as follows. 658 Part V Esophagus pharmacologic therapy. Smooth muscle relaxants such as nitrates or calcium channel blockers, administered sublingually immediately prior to eating, can relieve dysphagia in achalasia by reducing the less pressure. Amyl nitrite, sublingual nitroglycerin, theophylline, and beta-2 adrenergic agonists have also been tried. The largest reported experience has been with isosorbide dinitrate, isordil, and nifedipine. However, the side effects of nitrates, particularly headache, are common and the efficacy is very limited. Placebo-controlled trials have not been reported. With calcium channel blockers, mainly nifedipine, the limiting side effects are flushing, dizziness, headache, peripheral edema, and orthostasis. Sublingual nifedipine, 30 to 40 mg/day, administered before meals was studied in 29 patients with early achalasia and was significantly better than placebo, with good results in 70% of achalasics followed for 6 to 18 months. 87 However, a subsequent placebo-controlled crossover trial of nifedipine found minimal benefit. 88 Sildenafil, Viagra, is another smooth muscle relaxant that can decrease lay pressure in patients with achalasia by blocking phosphodiesterase type 5, the enzyme that metabolizes the cyclic guanosine monophosphate induced by NO. A double-blind placebo-controlled trial found that 50 mg of sildenafil significantly reduced lay pressure and lay relaxation pressure when compared to placebo. 89 The effect peaked at 15 to 20 minutes after administration and persisted for less than 1 hour. Although conceptually appealing, the practicality of using sildenafil clinically is limited by its cost and potential side effects. Botulinum toxin injection. The initial landmark study of botulinum toxin in achalasia reported that intrasphincteric injection of 80 units of botulinum toxin decreased lay pressure by 33% and improved dysphagia in 66% of patients for a 6-month period. 90 Botulinum toxin irreversibly inhibits the release of ACH from presynaptic cholinergic terminals, effectively eliminating the neurogenic component of lay pressure. However, because this effect is eventually reversed by the growth of new axons, it is not a long-lasting therapy. The technique involves injecting aliquots of botulinum toxin into 4 quadrants of the LES with a sclerotherapy catheter. Side effects are rare but can include chest discomfort for several days and occasional rash. Although many patients initially experience a good response, there is minimal continued efficacy at 1 year. 91 Repeat injection can be effective, but the injections lead to a local inflammatory reaction and fibrosis, ultimately limiting that strategy. Doses greater than 100 units do not have increased efficacy. 92 Hence, this option is best reserved for older adults or frail individuals who are poor risks for definitive treatments. Pneumatic dilation. Therapeutic dilation for achalasia requires distension of the LES to a diameter of at least 3 cm to effect lasting reduction of lay pressure, presumably by partially disrupting the circular muscle of the sphincter. Only dilators specifically designed to treat achalasia achieve adequate diameter for lasting benefit. Dilation to a lesser diameter provides only very temporary benefit at best. Rigiflex dilators are available in 3.0, 3.5, and 4.0 cm diameters. These are long, non-compliant, cylindrical balloons that have radio-opaque markings. They are designed to be passed over a guide wire and positioned across the LES fluoroscopically. Once positioned, the balloon is inflated to full diameter using a handheld manometer, taking care to visualize the indentation of the sphincter on the balloon surface as it expands. Pneumatic dilation is commonly done on an outpatient basis with the patient under conscious sedation. However, the technique of pneumatic dilation is highly variable among practitioners in terms of patient preparation, parameters of balloon inflation, and post-dilation monitoring. 93 In patients with substantial esophageal retention, it is useful to impose a clear liquid diet for 1 or more days prior to the procedure. Although there is minimal methodological consistency among authors, a cautious approach of beginning with a small diameter dilator, 3.0 cm, and progressing to larger diameters, 3.5 and 4.0 cm, only when the smaller dilator proved ineffective, is fairly universal. As for inflation pressures, these are of minimal relevance with modern non-compliant balloon dilators, because they do not distend beyond their specified diameter regardless of inflation pressure. Hence, it is simply necessary to observe under fluoroscopy that the balloon is properly positioned to capture the LES, observed as the waist of the hourglass-shaped balloon silhouette, and that the waist fully effaces as the inflation proceeds. The major complication of pneumatic dilation is esophageal perforation, with a reported incidence ranging between 0% and 5% and a global average of 1%. 86 With most perforations readily evident, or at least suspected, within an hour of the procedure because of persistent or severe chest pain, fever, or subcutaneous emphysema, patients should be observed for signs of an esophageal leak for at least 2 hours after pneumatic dilation. Alternatively, some practitioners routinely obtain a fluoroscopic examination of the esophagus following pneumatic dilation to ensure that perforation has not occurred. Usually, water-soluble contrast is given first, followed by barium. If a perforation appears small and is contained or intramural, conservative management consisting of hospitalization and close observation while maintaining the patient NPO, administering 4 antibiotics is appropriate. Larger perforations can be closed with endoclips. However, if a perforation is substantial, or if worsening chest pain and fever occur, surgical repair should be pursued expediently. Patients with a perforation from pneumatic dilation that is recognized and promptly treated surgically, within 6 to 8 hours, have outcomes comparable to those of patients undergoing elective Heller myotomy. 94 In instances of an unsatisfactory result following pneumatic dilation, it is reasonable to perform a subsequent dilation within a matter of weeks, using an incrementally larger dilator. If the benefit of the original dilation persisted for a year or more, it is common to repeat pneumatic dilation as necessary. The clinical efficacy reported for dilation ranges widely from 32% to 98%, likely because of the extreme variability in technique, methods for assessing treatment outcome, and the acceptability of performing repeated dilations over time. 93 Subsequent response to surgical myotomy is not influenced by the history of previous dilatations. Heller myotomy. Current surgical procedures for treating achalasia are variations on the esophagomyotomy described by Heller in 1913. Subsequently, this procedure was modified to an anterior myotomy via thoracotomy. The appeal of myotomy is that it offers a more predictable method of reducing lay pressure than does pneumatic dilatation. Although clearly efficacious, open Heller myotomy is associated with considerable morbidity related to the thoracotomy. However, adoption of the laparoscopic approach for achalasia surgery has largely mitigated this. Published series of the efficacy of Heller myotomy in treating achalasia report good to excellent results in 62% to 100% of patients, with persistent dysphagia in fewer than 10%. The laparoscopic approach is associated with similar efficacy, reduced morbidity, and shorter hospital stay compared to myotomy via thoracotomy, laparotomy, or thoracoscopy. In the past, post-myotomy gastroesophageal reflux could be particularly severe. However, with the use of PPIs, this is usually easily controlled. Thus, laparoscopic Heller myotomy combined with a partial fundoplication, toupee or door, has become the preferred surgical procedure for achalasia. An unsatisfactory result following Heller myotomy can result from incomplete myotomy, scarring of the myotomy, functional esophageal obstruction from the anti-reflux component of the operation, paraesophageal hernia, or severe esophageal dilatation. Chapter 44 Esophageal Neuromuscular Function and Motility Disorders 659-44 Only one multi-center prospective randomized controlled trial exists comparing pneumatic dilation to laparoscopic Heller myotomy. 83,84 In the European achalasia trial, 200 achalasia patients were randomized to laparoscopic myotomy with door fundoplication or pneumatic dilation, allowing for a maximum of 3 series of dilations in the pneumatic dilation group. There was no difference in success rates after 2 years of follow-up, 92% for pneumatic dilation versus 87% for laparoscopic myotomy. 84 Based on that evidence, laparoscopic myotomy and pneumatic dilation have comparable success rates, and cogent arguments can be made for each of these. Hence, one should assess the available local resources, as well as patient preference, in selecting the initial therapy. Per-oral endoscopic myotomy, POEM. More recently, a hybrid technique has been developed for treating achalasia, essentially using endoscopy to achieve a surgical myotomy. This procedure, termed per-oral endoscopic myotomy, POEM, requires making a transverse mucosal incision in the mid-esophagus, entering it, and creating a submucosal tunnel all the way to the gastric cardia using a forward-viewing endoscope with a transparent distal cap and a triangular dissection knife. Once the subcutaneous tunnel is complete, the endoscope is withdrawn and selective myotomy of the circular muscle accomplished with electrocautery tools for a variable length up the esophagus and 2 cm distal to the EGJ onto the gastric cardia. Endoclips are then used to seal the entry incision. Initial reports in prospective cohorts of achalasia patients treated with the POEM procedure reported success rates of greater than 90%, comparable to those of laparoscopic Heller myotomy. A recent systematic review and meta-analysis comparing outcomes of POEM, 1958 patients, and LHM, 5,834 patients, found POEM to be more effective than LHM in relieving dysphagia in the short term, mean follow-up 16 months, but associated with a very high incidence of pathological reflux, odds ratio of 9.31 for erosive esophagitis, 0.95. A randomized controlled trial published as an abstract in 2017 comparing POEM with pneumatic dilation found the POEM procedure to be more efficacious in terms of therapeutic success, but also more likely to result in post-procedure reflux esophagitis. 0.96 after 1 year, 92% of the POEM patients, N equals 67, were in clinical remission versus 70% after pneumatic dilation, N equals 66, p 0.01. Treatment failures. Persistent dysphagia after achalasia treatment suggests treatment failure and should be evaluated with some combination of endoscopy, high-resolution impedance manometry 97, functional luminal imaging probe 98 and fluoroscopic imaging. Endoscopy may detect esophagitis, stricture, paraesophageal hernia, or anatomic deformity. Impedance manometry may be useful to quantify persistent or recurrent sphincter dysfunction, distal spasm, or esophageal retention. Functional luminal imaging probe study can identify a poorly distensive sphincter, even in cases that HRM suggests adequate relaxation. 0.99 Fluoroscopy is useful both to identify anatomic problems and to evaluate esophageal emptying using a timed barium swallow, a standardized method of measuring the height of the esophageal barium column 1 and 5 minutes after ingestion. 0.97 In some instances, these evaluations will lead to further intervention. This could potentially be either repeat dilation, POEM, or Heller myotomy. In patients who have already undergone myotomy, detection of a short myotomy or functional esophageal obstruction from the anti-reflux component of the surgery may require reoperation, but pneumatic dilation can be pursued as an alternative. Reoperation, in general, is less effective than an initial operation for any indication in achalasia. Occasionally, patients fail to respond to optimally performed dilation or myotomy and require alternative treatment. In extremely advanced or refractory cases of achalasia, esophageal resection with gastric pull-up or interposition of a segment of transverse colon or small bowel may be the only option. Indications for this intervention include unresolvable obstructive symptoms, malnutrition, bleeding, chronic aspiration, cancer, and perforation during dilation. Although excellent long-term functional results can be achieved, the reported mortality of this surgery is about 4%, consistent with esophagectomy done for other indications. Risk of squamous cell cancer. Squamous cell carcinoma may develop in the achalasic esophagus. The tumors develop many years after the diagnosis of achalasia and usually arise in a greatly dilated esophagus with stasis esophagitis. Symptoms attributable to the cancer can be delayed, and the neoplasms are often large and advanced at the time of detection, raising the issue of surveillance endoscopy. However, an analysis of a database encompassing the entire Swedish population of 1,062 achalasics suggests that after discounting incident carcinomas, the overall squamous cell cancer risk for achalasics was 17-fold compared to age-matched controls, resulting in a 0.15% cancer incidence. The authors calculated that if surveillance endoscopy was done annually, 406 exams would have to be done in men and 2,220 in women before one potentially treatable tumor was found. However, even that calculation is optimistic, given that detection of a small cancer in a massively dilated esophagus with retained food and stasis esophagitis is far from assured. Consequently, the latest ASGE guidelines do not advocate routine endoscopic surveillance for achalasia patients. However, they also state that if surveillance was considered, it would be reasonable to begin 15 years after the onset of achalasia symptoms. 100 Diffuse esophageal spasm, DE. Despite the dogma of treatment with smooth muscle relaxants, minimal controlled data exist regarding pharmacologic therapy of DE. 101 Long-term studies are not available, and the entire basis for this therapy is anecdotal. Furthermore, most instances of esophageal chest pain are due to reflux rather than DE, and reflux symptoms will likely be made worse by treating with smooth muscle relaxants. Uncontrolled trials of small numbers of DE patients report clinical response to nitrates, calcium channel blockers, hydralazine, and anxiolytics. Botulinum toxin injection is an appealing therapeutic approach for DAY because it blocks cholinergic neural transmission. In a randomized controlled trial involving 22 patients with DAY or nutcracker esophagus, 50% of patients responded to Botox, compared to 10% injected with saline, p 0.01, 0.102 in a subsequent retrospective analysis of only the patients diagnosed with HRM. All 6 with DAY had a positive response to Botox at 2 months and the response was sustained for more than 6 months in 4 patients. 103 However, a case of fatal mediastinitis was reported in a DAY patient who received Botox, so the procedure cannot be viewed as without risk. 104 Until recently, surgery was rarely entertained in the treatment of DAY because the options were of either a thoracotomy with a long myotomy or esophagectomy. However, since 2012, well-defined cases of DAY have been successfully treated with POEM. 105 The unique advantage of POEM is that the length of myotomy can be extended to potentially involve the entire smooth muscle esophagus as gauged by HRM, esophageal wall thickening on EUS, or intraoperative flip. Supportive of this, a recent meta-analysis of uncontrolled POEM series reported a weighted pooled response rate of 88% CI 61% to 97% in DAY with the length of myotomy averaging 13.5 cm. 106 Hypercontractile, jackhammer, esophagus. The same therapeutic options used for DAY have also been advocated for patients with hypertensive, or hypercontractile, 660 Part V esophagus peristalsis. Smooth muscle relaxants such as calcium channel blockers and nitrates have been used for these disorders. Although they reduce peristaltic amplitude, neither has been shown to relieve chest pain or dysphagia in clinical trials. Sildenafil is an appealing alternative owing to its profound effect of reducing contraction amplitude and potentially reducing the occurrence of repetitive contractions. 107 Again, supportive clinical trial data do not exist. Similarly, botulinum toxin injection in the esophageal muscle, with or without EUS guidance, may be an option for patients with refractory symptoms. Finally, similar to the cases of spastic achalasia and DAY, POEM has recently been proposed as a treatment for hypercontractility. The same meta-analysis of uncontrolled POEM series discussed above with respect to DAY also analyzed data on jackhammer and reported a weighted pooled response rate of 72% CI 55% to 83%, notably less than the 92% response reported for type 3 achalasia. 106 Because of the potential overlap between hypertensive peristalsis and GERD and the observation that many of these patients have coexistent psychological distress, therapies targeting acid secretion, visceral sensitivity, and stress have also been attempted. PPIs have been proposed based on the hypothesis that GERD can induce chest pain and hypertensive peristalsis. Similarly, treatment with low-dose tricyclic antidepressants may reduce contractions via the anticholinergic effect and may reduce visceral sensitivity. Absent peristalsis. Although it is biologically plausible that treating an underlying disorder associated with absent peristalsis may improve esophageal motility, no medications have been identified that significantly improve peristalsis in the context of absent peristalsis. Consequently, treatments focus on minimizing potential complications using lifestyle modifications such as postural maneuvers to improve esophageal clearance and drinking liberally with meals to facilitate bolus transit. Patients with absent peristalsis and an incompetent EGJ, the scleroderma pattern, will be vulnerable to severe GERD because they have both a reduced anti-reflux barrier and impaired esophageal clearance once reflux has occurred. See Chapter 46. These patients often require twice-daily PPI therapy. Additionally, these patients are vulnerable to pill esophagitis, and care should be taken to avoid potentially caustic medications and to convert medications to liquid formulation, sublingual, or smaller versions to prevent pill esophagitis. Esophageal hypersensitivity therapies for esophageal motor disorders have traditionally centered on improving esophageal contractility and emptying. However, other than in the instance of achalasia, the efficacy of these therapies is very limited. More recently, there has been a realization that minor manometric findings formerly interpreted as indicative of symptomatic hypercontractile conditions were often epiphenomena indicative of hypersensitivity syndromes. Hence, there is now substantial interest in developing treatments directed at reducing esophageal hypersensitivity, and a number of pharmacologic and behavioral therapies have been identified to modulate esophageal pain perception. Pharmacologic treatments. Antidepressants are the most common medications prescribed for visceral pain modulation or chest pain of esophageal origin. Among the antidepressants, the tricyclic antidepressants are the best studied. The mechanism of action for this therapeutic benefit is unknown, because these agents have multiple receptor targets, both centrally and peripherally. Proposed treatment with these agents is at lower doses than would be used for mood-altering effects, and typical starting doses for antidepressants, amitriptyline, nortriptyline, are 10 to 25 mg at bedtime, with escalations of 10 to 25 mg increments to a target of 50 to 75 mg. However, as highlighted by a recent randomized controlled trial, it is difficult to differentiate the nonspecific effects of tricyclics from their effects on hypersensitivity. 108 In that trial of 43 functional heartburn and esophageal hypersensitivity patients randomized to treatment with 25 mg QHS imipramine and 40 randomized to matched placebo, the response rates, judged by a 50% reduction in reflux symptoms, were 37.2% and 37.5%, respectively. However, those treated with imipramine were more likely to experience improvement in quality of life as assessed by total SF-36 score, which is, after all, the main objective when treating functional disorders. Experimental data also support the effectiveness of selective serotonin reuptake inhibitors in the treatment of esophageal hypersensitivity. Intravenous citalopram at a dose of 20 mg was found to significantly reduce both chemical, acid perfusion, and mechanical, balloon distension, esophageal sensitivity in a randomized double-blinded crossover study. 109 Although clinical trials are not yet available, mechanistic studies assessing other selective serotonin reuptake inhibitors have also yielded encouraging results. Along similar lines, there has been substantial interest in developing medications that influence serotonin, 5-HT, pathways given their effects on gut motility and as treatments for nausea. Unfortunately, several of these medications have proved to have unacceptable risks related to cardiac arrhythmias or gut ischemia that led to their withdrawal. Non-pharmacologic treatments. Although the link among esophageal hypersensitivity, psychological factors, and psychiatric abnormalities is unclear, therapy focused on reassurance, behavioral modification, and relaxation techniques may be helpful. These therapies will most likely benefit patients with comorbidities such as panic disorder, generalized anxiety, and depression. However, it is also possible that therapies using controlled breathing, relaxation techniques, or hypnotherapy may benefit patients with hypersensitivity by diverting mental attention and reducing hypervigilance for visceral stimuli. Well-performed prospective trials are necessary to define the clinical role of these therapies.